Hello, good morning, everybody. My name is Dr. Montenegro. I am currently an ultrasound fellow at Jacobi Medical Center, and I would like to welcome everybody that's tuning in to our annual conference. This is the 13th annual Emergency Medicine and Critical Care Conference in collaboration with the Jaja Foundation. Again, hello. I think I'm just coming on. Hi, my name is Dr. Montenegro. I am an emergency medicine attending at Jacobi Medical Center, and I'm currently in the middle of my ultrasound fellowship. I would like to welcome everybody that's tuning in to our 13th annual Emergency Medicine and Critical Care Ultrasound Conference. Thank you for joining us today. We have a day full of excellent teaching didactics, and we're happy you have joined us today. Before we begin, I would like to acknowledge our partners, Dr. Trevor Dixon, CEO and founder of the Jaja Foundation, the team at Jacobi Medical Center, Dr. Hugh Wong and his team at Kingston Public Hospital, Dr. Simone French and her team at the University Hospital of the West Indies, Orlando Dillon from Evisive Media for providing the live streaming of the event. And I would like to acknowledge our media sponsors, Russ Clem of Grubin Radio, WVIP FM 93.5, Dervin Malcolm and the team at Power 106, Jamaica, who has always supported the foundation's initiatives, Mr. Edwin Clare, and Erie Jam Radio. I'm going to explain a few rules before we begin. The event is being recorded and it is live on both YouTube and Facebook. A link is going to be shared with the participants for you to complete your information in order to get a CME certificate. Please note that if you're tuning into our event today, you need to complete the form in its entirety in order to receive the CME certificate, and anybody whose medical profession requires a CME certification can participate and request the certificate. We ask that you hold your questions towards the end of the presentation. There is a Q&A section where you can comment questions. And at the end of all the lectures, we will be having a Q&A session in order to address any questions that might arise during the lectures. I'd like to encourage you to subscribe and like our Facebook and YouTube page. And again, the CME certificates will be emailed to the participants a few weeks after the conference. A link at the end of the presentations is going to be sent. It's order for you to fill out an anonymous survey. It will be sent via social chat, again, at the end of the session in order to evaluate our event. Without further ado, I'd like to start with opening remarks. First, I'd like to introduce Dr. Trevor Dixon, founder and CEO of the Jaja Foundation. And he's an emergency medicine attending at Jacobi Medical Center and the director of clinical ultrasound at Jacobi Medical Center. Dr. Dixon.
Good morning. I'd like to welcome everyone here for being at our 13th ultrasound conference and our first virtual conference. I would like to send a warm welcome to everyone. And when I say warm, I mean warm. It's about 17 or 18 degrees here in the New York City area, and it's cold. And we just want to say, if you wherever you're tuning in from, whether it's the United States, one of the other states, or in the Caribbean, or out of London, wherever you are, we send a warm welcome in our 17 degrees here in New York. A special shout out to the team at the Kingston Public Hospital, Dr. Wong and his team, Dr. French and the team at the University of the West Indies, and of course, the team at the Jacobi Medical Center, HHC, here in the Bronx, New York. This is, of course, our first virtual conference, but our 13th annual emergency ultrasound and critical care conference. The first was held at the Kingston Public Hospital over 13 years ago. That was a brainstorm between Dr. Wong and myself. And I want to thank everyone for giving up their Sunday morning to join us. And as I said before, it's very cold here. And the genius that I am, usually every January, we're down in Jamaica around this time of the year for our ultrasound, for not just the ultrasound, but for our medical mission. I always plan a conference at the Knutsford Court Hotel and we always find folks willing to go down to join us and interact with the sisters and brothers living in Jamaica. We are not we are not charging for this conference, but as a non-for-profit, we rely solely on contributions and donations so that we can stay afloat. So please, if you can afford, please go on the website and make a donation. We take up to $1 million, so please go on the webpage and we have the capacity to take up to $1 million. If you're sending greater than $1 million, we're going to have to reject that today. You can send it by check. Uh, it- um, as Coffee has said, if you make a donation to us, you don't have to worry because blessings will fall not only on your right hand, but it will also fall on your left hand also. This conference is only one of several initiatives that we have on the island of Jamaica. Please visit our website and our Facebook page to learn more about what we do. I want to thank all the presenters who have made the sacrifice to be here on this cold Sunday morning. I want to thank all the other support staff that's here. Um, Linda's here from Jacoby. Thank you for being here. We have Orlando Dillon and Garvin Gray and a lot of people who are behind the scene at KPH and the University of the West Indies to make this happen. It is so tremendous. One of our presenters is actually presented from Ecuador. So it just goes to show you the possibilities when we put our minds together. And despite the negative effects of COVID, we've learned some interesting and innovative ways of how to survive. So um, our condolences to those people who are suffering or have lost people during COVID-19. But this too shall pass, and we will triumph. So thank you all for being here again, and we'll just get the conference going. Thank you.
Thank you, Dr. Dixon. Um, I would like to remind all the participants, thank you, Dr. Dixon. I'd like to remind all the participants that are presenting, while you're not presenting, to please mute your mic and turn off your video. Next, we will have a few remarks from Dr. Hugh Wong. He is an emergency medicine consultant and head of the Department of Accident and Emergency Medicine at Kingston Public Hospital. Dr. Wong.
Good morning. Good morning. The 13 years that have passed since Dr. Dixon persuaded me to join him on the ultrasound journey is unbelievable. When it is said that something had humble beginnings in what we are doing here today, epitomizes that. We must remember that the ultrasound conference preceded what we now know as the Jaja Foundation. From the first few years of seeking local sponsorship, literally begging, and having the meetings at the Kingston Public Hospital and at least one memorable meeting at the Corner Regional Hospital, to now having a local coordinator and having the meetings at hotel lecture rooms, the aim has always been the empowering of emergency physicians and critical care staff to give them another tool in their toolkit. And even when that tool isn't available to them, prepare them just in case. Building capacity, and in so doing, providing improved healthcare for Jamaicans is the ultimate aim. Although this year's format and presentation is through virtual means and a great conference is anticipated, I'm sure the 14th edition of this conference will be as it was on the 12th, hands-on and personal. So we expect to see Dr. Dixon and his team back in sunny Jamaica, January 2022. Virtual meetings and telemedicine can occur planned and impromptu. But in the medical education space, meetings such as this can serve only to augment teaching techniques. This is most marked in the specialty of emergency medicine, as advanced cardiac life support and trauma support and the skill of placing chest tubes simply cannot be delivered by Zoom. I wish to thank the organizers and welcome the presenters and the participants on Facebook and YouTube to our 13th annual Emergency and Critical Care Conference. Let's all have a great conference. And remember, give generously to the Jaja Foundation. They are doing great work. Thank you.
Again, thank you. Thank you, Dr. Wong. Thank you so much, Dr. Wong, for those words. Trust you, me, all the team at Jacobi cannot wait. We're hopeful that next year we can certainly be sharing these learning experience with you in Jamaica in person. I'm looking forward to it. So we're ready to start our conference day now. Our first lecturer, I have the pleasure of sharing the Clinical Ultrasound Fellowship with. It's Dr. Nahama Sonnenthal. She's an ultrasound fellow and attending physician at Jacobi and North Central Bronx Hospitals, and she's a clinical instructor at Albert Einstein College of Medicine. She will be talking to us today about the traumatic patient. Take it away, Dr. Sonnenthal.
Hello, thank you, Dr. Montenegro, for the introduction. My name is Nahama Sonnenthal, and like Dr. Montenegro said, I'm an emergency medicine attending and ultrasound fellow at Jacobi Medical Center in New York. Today, I will be talking about the EFAST, which stands for the Extended Focused Assessment with Sonography for Trauma. The FAST exam is a point-of-care ultrasound exam used in trauma patients to detect intraperitoneal and intrathoracic free fluid.
We can see you, Doc. Please proceed.
Okay. So like I was saying, sorry, we're just trying to get the screen to share on the, okay, let's see. Okay. It's good. Okay, it's just that it's good. Sorry about that. I'm going to start from the beginning. So the FAST exam is a point-of-care ultrasound exam used in trauma patients to detect intraperitoneal and intrathoracic free fluid. This is helpful in a busy emergency department or in a limited resource setting to rapidly detect injury in a trauma patient and quickly direct them to the appropriate care. The extended FAST exam was created in 2004, which added the lung ultrasound to the FAST exam to assess for pneumothorax, which makes it be called the EFAST exam. Indications to perform an EFAST exam include blunt or penetrating chest or abdominal trauma, and the EFAST exam can be used in pregnant and pediatric patients. The FAST data was originally published as early as 1981 in Germany, but it was only adopted in the United States in the 1990s, likely because the original data was only published in German and not English. The FAST exam is up to 90% sensitive and 99% specific for detecting intraperitoneal and intrathoracic free fluid, and can detect as little as 250 milliliters of free fluid, for example, in Morrison's pouch in the right upper quadrant. Before the EFAST existed, we used the diagnostic peritoneal lavage, or the DPL, as well as the CAT scan to detect injury in trauma patients. Unlike the EFAST, the diagnostic peritoneal lavage requires a needle, is invasive, and can come with complications. And because it is very sensitive, it can also lead to a false positive rate. In contrast, the EFAST is non-invasive and more user-friendly. So it is recommended to use the EFAST instead of the diagnostic peritoneal lavage. However, the CAT scan has some benefits over the EFAST, such as the CAT scan can detect hollow viscous injury, can detect the source of bleed, and can detect retroperitoneal bleeds. On the other hand, the EFAST has some advantages over a CAT scan, such as no radiation or contrast, and it is a bedside test that can be done quickly. Therefore, because of the advantages each one has over the other, it is recommended that the EFAST be done in conjunction with the CAT scan and not just replace it. The American College of Surgeons created the Advanced Trauma Life Support Protocol, which delineates how to run a trauma when a patient comes in. So when do you do the EFAST? When do you do an EFAST when dealing with a trauma patient? So if a patient is unstable, this can be done as part of the primary survey. When checking someone's circulation, if someone's hypotensive in a trauma, the EFAST can be used to detect the cause of the shock. If a patient is stable, then the EFAST can be performed as part of the secondary survey or between the primary and secondary survey. So there's different components of the EFAST. There's the cardiac, the lung, the right upper quadrant, the left upper quadrant. So which one do you do first? You can do whichever part of the exam is most pertinent based on suspicion. So if someone has a knife sticking out of their chest, then you may want to start with the cardiac view or the lung view. But if someone's undifferentiated and you're not really sure where their injury is, it's good to know that the right upper quadrant is the most specific for ruling in intraperitoneal free fluid, and you may want to start there. And which probe should you use for the ultrasound exam for the EFAST? We recommend that you use the best probe for the exam that you're doing, and we'll explain. So if you do start with the right upper quadrant portion of the EFAST, we recommend that you use the curvilinear probe for this portion. The most sensitive spot for detecting free fluid in the right upper quadrant is between the caudal tip of the liver and the kidney. Here's an image showing free fluid between the liver and the kidney in the right upper quadrant, the black portion here. Here's an example of positive free fluid in Morrison's pouch, which is the space between the liver and the kidney. The anechoic stripe represents free fluid. Here's an image showing positive free fluid in the paracolic gutter of the kidney, which is the inferior portion beneath the kidney. And it can be seen in both the right upper quadrant and left upper quadrant, as seen here. Here's an example of a normal right upper quadrant view. You could see the liver and the kidney, and then posterior to that, you could see a hyperechoic line, which represents the spine. Supradiaphragmatically, above the superior to the diaphragm, you do not see the spine extended. That is because the ultrasound waves travel well through solid organs such as liver and the kidney to reflect on the spine. But in a normal aerated lung, the ultrasound waves will not travel through air very well, and you will not be able to see the spine in a normal lung situation. This is called a negative spine sign and is normal. However, if the thorax above the diaphragm was filled with fluid, the ultrasound waves would travel better in that medium, and you will be able to see the spine, such as in this image. This is called the positive spine sign, and it indicates that there's fluid instead of air in the thorax. So if you do see the spine above the diaphragm, superior to the diaphragm, this is called the spine sign, and it's not normal and it indicates there's fluid in the lung base, such as blood in a trauma. Next, you can move to the left upper quadrant portion of the EFAST. We still recommend to use the curvilinear probe, and the most sensitive spot for detecting free fluid in the left upper quadrant is between the diaphragm and the spleen. Here's an example of positive free fluid in the splenodiaphragmatic space between the spleen and the diaphragm in the left upper quadrant. Here's an example of positive free fluid between the spleen and the left kidney in the left upper quadrant. Again, you can look at the lung base in the left upper quadrant as well, and if you see a positive spine sign, that is not normal, and it indicates that there's fluid in the lung base above the diaphragm, superior to the diaphragm. Next, you can move to the pelvis view of the EFAST. Again, we recommend the curvilinear probe for this portion, and you should conduct this part of the exam both longitudinally and sagittally. Here's an example of free fluid in the pelvis view adjacent to the bladder. The anechoic, poorly delineated hypoechoic and echoic area is blood. Next, you can move to the cardiac portion of the EFAST. For this portion, we recommend that you use the cardiac, also known as the phased array probe, to conduct this portion of the exam for optimal views of the heart. Although it's often taught to start with the subxiphoid view, you can actually use any of the 4 classical views used in the focused cardiac echo for the EFAST. So you can use the parasternal long axis or the parasternal short axis or the apical forechamber or the subxiphoid view to look for free fluid around the heart. Here's an example of free fluid around the heart, a pericardial fusion in the EFAST portion of the cardiac view. Next, you can move to the lung portion of the EFAST. For this portion, you will be using the linear probe to look for a pneumothorax. So on this side of the screen, you can see the 2 rib shadows, and in between, you should be able to see the pleura between the two ribs. And it's a little cut off, but in a normal lung sliding scenario, you will see that the pleura is shimmering. And that is normal, and it indicates the lung is normal, there's no pneumothorax. On the right side of the screen, you can see the 2 ribs, and you can see the pleura, and you could see that it's not shimmering or shining, and it's not moving at all. And that is indicating absent lung sliding. And typically that's associated with a pneumothorax, but there are other reasons why the lung might not be sliding. It simply indicates the lung isn't moving. So imagine that there's someone with a right main stem intubation, and you're looking at the left lung. Because the left lung is not being aerated, you won't see any lung sliding because the lung isn't moving on the left side, but it's not necessarily a pneumothorax. So in order to confirm the pneumothorax, you can slide your probe laterally and look for what's called a lung point. So a lung point is shown here. So you can see the rib again, you can see the pleural lining right here in the middle, and in the same contiguous portion of the pleural lining, you can see one part is shimmering. That's what was supposed to be on the other screen. It's normal shimmering lung sliding, and continuous with that is another portion of the lung that's completely stagnant and not sliding at all. The point between the shimmering lung and the part of the lung that's not moving is called the lung point, and that is extremely sensitive, specific for ruling in a pneumothorax. So if you do find the lung point, then that is very specific for ruling in a pneumothorax. So to summarize, if there is lung sliding and it's shimmering, that indicates there's no pneumothorax. If there's no lung sliding, it indicates there's a possible pneumothorax, and you can slide your probe laterally to look for the lung point, which is highly specific for ruling in a pneumothorax to confirm. One thing that's often done in a trauma that's very hectic is everyone will be asked to clear the room to get the chest x-ray. It's of high importance. But here are some characteristics comparing the EFAST and the chest x-ray. The EFAST can detect as little as 20 milliliters of fluid at the lung base, whereas the chest x-ray can require up to 50 to 175 milliliters to detect fluid in the lung base. The EFAST, if you find a lung point, this is highly, highly specific, almost 100% specific for ruling in a pneumothorax, whereas a chest x-ray may miss up to 29 to 72% of occult pneumothoraces. So the EFAST is superior to the chest x-ray in detecting free fluid in the lung as well as pneumothorax. So what happens if the EFAST is positive? Well, if you find a pneumothorax or a hemothorax on your EFAST exam, if it's indicated and let's say the patient's unstable, you can place a chest tube. And if the patient's stable and you have some more time, you might choose to get further imaging to see what's going on in the chest. If you do the cardiac view and you find fluid around the heart, you have to clinically decide, is there tamponade, is it just an effusion, and is the patient stable or not. It may be clinically indicated to do a pericardiocentesis emergently. They may be stable enough to go to the operating room to remove the fluid, or they might just need further workup with a consult or observation. If the fast portion detecting fluid in the abdomen is positive or indeterminate, and the patient is stable, you may choose to get a CAT scan for that patient to further delineate their injury. If the FAST is positive or indeterminate for fluid in the abdomen and the patient is unstable, they probably should go to the operating room to take care of the issue since you identified free fluid. If the FAST is negative and the patient is stable, you may choose to do serial EFAST exams, or if clinically indicated, you may choose to get a CAT scan. And if the FAST is negative and the patient is unstable, then you need to look for another source of why the patient is unstable, however that's clinically indicated. So that's the end of the EFAST portion of the exam. And if you have any questions, you can type them in and send them our way. Thank you for listening.
Hello. Thank you, Nahama. Thank you, Nahama, for that lecture. Next, I'm going to be giving the participants a chat on thoracic ultrasound in the emergency department. Let me just start my screen sharing. All right. And again, my name is Dr. Montenegro. I am an emergency medicine attending at Jacobi Medical Center. So what I'm hoping to do with my talk is kind of demystify an approach to the thoracic ultrasound for both novice learners and experienced clinicians. My hope is that ultimately, with enough practice, you can see that ultrasound is something you can easily integrate into the care of your patient, and kind of can greatly expedite or better inform your management of a patient. So I'm sure in whatever setting you're working in, if you're working with critically ill patients, at least once a shift, you'll have a patient that is in respiratory distress, especially now in the age of COVID. I'm sure we're seeing a slight increase in the patients that are presenting to us hypoxic. And sometimes it can be tricky to really determine, is it COVID, is it a PE, is it asthma? Sometimes, because we're seeing patients essentially in extremis. So I want to kind of impart on you how ultrasound can help you demystify what might be going on with the patient with a pretty simple approach. So why ultrasound? At least when we get our trauma notifications or a critically ill patient, our trauma base can get crowded like this. Obviously, ultrasound is a much smaller, portable machine that we can sneak in there while all the action is going on and try to, get more information about what's going on with the patient. So it's fairly portable, an X-ray and a CAT scan, as you know. Of course, much more cumbersome to obtain. Sometimes it's just not possible to get it within a timely fashion. Also, ultrasound does not have radiation, so you can do it on pregnant patients, and it requires a single provider essentially to obtain the images and interpret. So in the age of, again, with the pandemic going on, this can be beneficial in terms of minimizing exposure to the providers. Ultrasound also, there's been a wealth of literature for decades now that have studied the sensitivity and specificity of ultrasound and evaluating multiple pathologies in the thorax in addition to other areas of the body. And it's been demonstrated that even novice learners can perform these studies and learn them fairly quickly. Ultrasound, as we mentioned earlier, is excellent at detecting pneumothoraces. It's much more sensitive than a chest X-ray detecting pleural effusions. For the evaluation of pneumonia, it's just as good as a CAT scan. And let's be honest, we're not CAT scanning pneumonias on a routine basis. So it can be a really great tool to add to your arsenal as you evaluate your patients. So a general approach that I like to impart on the learners, and as we, even if you're an advanced user, obviously, like you'll hear me say this over and over and over again when I'm teaching, it's all within the clinical context of the patient. Super important to keep that in mind. Obviously, the ultrasound just adds a tiny bit of information to our overall assessment of the patient, but that does not replace what we're seeing, the story we got, what we have in front of us, our clinical gestalt, our clinical knowledge of how to manage the patient. So definitely use the information you're obtaining from your studies in the clinical context of what you're seeing from the patient. It's also important and helpful as a provider to understand the characteristics of the pathologies being evaluated. And something that's super important is to make sure that you're using the right probe for your studies and the right machine settings. So with that in mind, in general, with thoracic ultrasound, we're essentially evaluating, I would say, 3 things. There's 3 simple things that you want to get information out of when you're doing a thoracic ultrasound. One is the pleural line. And for that, the linear probe will give you the best picture because it's super high resolution. It'll give you nice details of that superficial structure. And the 2 other things that you're interested in is evaluating the lung parenchyma and the lung basis. For that, a curvilinear or phased array probe would be ideal. So again, as I said, there's been decades of literature on thoracic ultrasound. There's multiple protocols that have been devised, the Blue protocol, there's multiple scanning approaches. A lot of these protocols are meant to be used in a more intensive care unit setting. So, their approach is much more methodical and it divides the chest and the regions to scan into multiple sections. Obviously, with the acuity of the patients that we're seeing, we don't have the luxury of time to be scanning 28 fields in the front and 28 fields in the back. It would be a disservice to the patient that we have in front of us and to the patients that are waiting to be seen. So I would like to kind of reinforce that there's only really at minimum 4 areas that you should be looking at to kind of simplify these protocols that are out there. And it's essentially the parasternal regions and the lung basis. All right. So again, pleural line, you're going to want to use your linear probe and you're going to place the linear probe in the 2 parasternal regions, and we'll talk a little bit more about how to obtain your images there. And for the lung parenchyma evaluation and the evaluation of the hemithoraces, you can look again in the same parasternal regions and then move down to your lung basis, which is essentially the right upper quadrant and left upper quadrant views. If you slide up into the chest from your EFAST, you'll be able to evaluate the lung basis with that. So with this approach in mind, I was hoping to go over a few cases and we'll chat a little bit about basic lung ultrasound findings, how to identify them correctly and what they mean. So the first case is a 67-year-old male. He has history of asthma, congestive heart failure, hypertension, and hyperlipidemia. He was brought in by ambulance for progressively worsening shortness of breath. On presentation, you walk into the room, the patient you see is tachycardic, he's breathing kind of fast, his blood pressure is normal, thankfully, and he's setting 93%. He does not have a fever. I'm sure that, given our clinical settings, at least from my experience, sometimes it's a little difficult with all the hecticness going on, if the patient is especially really sick, to get a truly good physical exam. And sometimes because of various factors, given, like the patient or what have you, it can be challenging to get a good physical exam. But for our gentleman here, he's on the bigger side. So the neck, we're not able to really assess for JVD very clearly, but he does have wheezing. He has breath sounds bilaterally. And again, because of his body habitus, there seems to be some edema in the lower extremities, but it's a little hard to tease out. So obviously this gentleman has a lot of risk factors for why he could be short of breath. So the differential diagnosis here is fairly broad. It could be a CHF exacerbation, could he have an asthma exacerbation? So, what I encourage you to try to start thinking about is, as you're approaching these patients, it would be ideal if you could throw the probe on and follow the protocol, the simplified protocol that I'm mentioning, before you get your chest x-ray, as you're doing your physical exam, as you're part of your initial evaluation of the patient. So let's see. So let's say the x-ray machine is still on their way and you're able to throw a probe on the patient's chest. So this is what you're seeing. You have your phased array, and this is what you're seeing on the parasternal regions. And then at the lung basis, you remember to slide down basically your EFAS view. And this is what you're seeing in the basis of the lung. All right, so let's try to sort out what it is that we're seeing here. So essentially, a lot of lung ultrasound relies on essentially artifacts that are generated because of what's going on in the lung parenchyma. And the first thing we're seeing here, we're identifying, is what's called a B line. So I have an arrow here pointing, this is a rib shadow. Here and here, the bright hyperechoic horizontal line is going to be your pleural line. And B lines extend all the way from the pleura all the way down to the bottom of your screen. And this is why it's important to use a probe with a deeper penetration, because you want to see the edema or the artifact going from the lung pleura all the way down. If there are things that can look like B lines on the linear probe, but that can also be normal lungs. So I encourage you to throw either with an abdominal or phased array to really truly evaluate the lung parenchyma itself. And as we mentioned, and you'll see a lot of the concepts that we talk about on our lectures kind of cross over, the EFAS, the thoracic ultrasound, all these things kind of cross over, and there's concepts that overlap. So again, you're seeing a positive spine sign here. So at the lung basis, you have your diaphragm, your liver. Again, if you slide your probe up towards the thoracic cavity, you'll start to see lung. And normally, as we mentioned earlier, lung ultrasound waves do not travel well through air. So if your thorax is filled with air, which would be the expected normal, you would not see the ultrasound waves transmitted through. So you would not see the spine above the diaphragm. In this case, our gentleman looks like he has some fluid in the thorax, and we're seeing the spine right above the diaphragm there at the end. All right. So again, B lines, general scanning tips, you should increase your depth to about 10 centimeters for proper evaluation, and you have to make sure that they extend from the pleural line all the way to the bottom of the screen. In general, they move as the patient breathes, and they're equivalent to interstitial edema in the lung. They'll look kind of like, my favorite description of them is like a flashlight in a fog. That's kind of like the best way that I find to visualize what a B line should look like. And again, they go the entire depth of the ultrasound screen. So in our case one, again, we had a fairly broad differential in the beginning. Could this be asthma? Could this be CHF? But like by throwing our probes down in the described areas, we were able to better direct our treatment to more of a cardiogenic pulmonary edema. The findings that supported our diagnoses were B lines, so it's helpful if you can identify a B line. Also, I think it's fairly interesting. They've done part of the research studies that they've done. You can quantify I mean, our job is not to necessarily quantify how much pulmonary edema there is, but there is a pretty good correlation. They did studies on thoracic ultrasounds on dialysis patients before and after dialysis, and they saw that the B line, how like hyperechoic they were and how many of them there were decreased after they were dialyzed. So I thought that was pretty interesting. Again, some pitfalls. Again and again and again, I'm going to reiterate, you have to evaluate your patient within the clinical context of their presentation. B lines are not specific just for cardiogenic pulmonary edema. You can see them in ARDS and pulmonary contusion and COVID-19 and in pneumonia. So again, ultrasound is going to give you a clue as to what might be happening with the patient, but that does not replace us and our training and our evaluation of the patient we have in front of us, okay? So the next case is gonna be a 27-year-old female. She has no past medical history, but she began feeling really short of breath acutely and called an ambulance. When you walk into the room to evaluate her, she's in moderate distress, she's tachycardic, she's breathing pretty fast. Her blood pressure might be a little soft. I mean, she's skinny, but it might be that she's hypotensive and she's setting 90% on room air. She's afebrile. Again, you are not sure if you hear breath sounds bilaterally, but she does not have swelling of the legs. The calves look symmetric, but she's in a lot of distress, so it's a little hard to assess the patient. In terms of the differential diagnosis for a young female, it could be fairly broad. I mean, you don't know what medical history she has, so she could be having a really bad asthma exacerbation. She could have a clot, pulmonary embolus, a pneumothorax. So again, you know, this is, I want to impart it again and again. If you integrate thoracic ultrasound, it can be a pretty quick way to kind of better direct your management of the patient. Again, fairly broad, undifferentiated dyspnea. And this is what we find on the ultrasound. So this is on one of the sides. All right. We see something beating there and some like little vertical lines coming in. And on the other side, we're sliding up and down. And this is, again, in the parasternal regions. We're sliding up and down the parasternal regions, and we see this. So what do we make of these findings? So I wanted to discuss another artifact that comes up as part of the thoracic, you know, that we rely on as part of our thoracic ultrasound evaluation, which is A lines. We have the pleural line here. Another tip, because it can be confusing if you see so many lines on your screen with a linear probe. Is this a pleural line? It could be confusing to identify which one it is. The pleural line is directly underneath while you'll see your rib shadows, okay? So we have identified our pleural line. These horizontal lines that you see going deeper into the thorax are called A lines, and they can be normal. They're present essentially when the thorax is filled with air, and it's a type of reverberation artifact. All right. So in this patient, you saw A lines bilaterally, but there wasn't any long sliding on the right. You saw a long point and a long pulse on the one slide, okay? So we're gonna sort out what it is that those things, those terminologies mean. So this is lung sliding, as we discussed in the EFAS lecture. Lung sliding, again, we're identifying our pleural line directly underneath the ribs. And lung sliding is a horizontal movement. One of my favorite descriptions of how it looks is like almost like a little trail of ants going down a path. And you'll see the sparkling, shimmering horizontal movement. Again, there's this little vertical line that's coming into view that is not a B line, it's a Z line, it's normal lung. And again, we're using a linear probe, so we can't really see the deeper lung parenchyma to see that this horizontal line that was coming into view, in fact, kind of dissipates fairly narrowly. And if at the end of this clip, we're seeing what's called a lung pulse, it's also a normal ultrasound finding. And I encourage you to take a look at your patients with a linear probe on the left side of the thorax. This is just the cardiac movement being transmitted through the lung parenchyma. So again, as we discussed earlier, here we're seeing what's called a lung point. This is fairly specific for ruling in a pneumothorax, excuse me. And it's basically the point at which the pleura stops connecting up all the way to the chest wall. All right, so we see a lung point there, and that's fairly suggestive of a pneumothorax. We also stop seeing lung sliding as we slide up and down there. All right, and on this patient, we do not see a spine sign. Again, another example, if the thorax is filled with air, the ultrasound waves are not going to be transmitted, so you will stop seeing the spine above the diaphragm as the patient breathes. So for A lines, again, it's part of the deeper lung parenchyma, so you want to increase your depth to about 10 centimeters and use your phased array or abdominal probe. They're hyperechoic horizontal lines, and they do not change with breathing. Again, they're a type of reverberation artifact. It can be present in normal lung tissue. So if you see a patient that's short of breath and you see A lines, it could be a bronchospasm, it could be a clot in the lungs, but it can also be seen with pneumothorax. And Z lines, like we mentioned earlier, can mimic B lines, but they're really shallow. And that's why the phased array or abdominal probe are better for evaluating that lung parenchyma. They're short vertical lines and they're normal. So in terms of diagnosing a pneumothorax on thoracic ultrasound, the findings that support your diagnosis, if you don't see lung sliding, and if you're lucky to catch the lung point, that's highly specific to rule in a pneumothorax. If there isn't a pneumothorax, you will see lung sliding. You can see a lung pulse. Again, I encourage you to take a peek at your patient's left-sided, on the chest on the left side with the linear probe, so you can see that on a normal patient. And if B lines are present, even if you just see one, and again, those are like the hyperechoic vertical lines that are going all the way deeper into the pleura, even if you see one, that means that the lung is touching normally. The lung is not collapsed. So again, I'm going to reiterate again and again and again, clinical context. If you don't have lung sliding, as we mentioned in our previous lecture, this doesn't only mean pneumothorax. It can be seen if the patient has severe atelectasis, if they have severe consolidations, if their tidal volumes are low, if there's a pleural adhesion, for example, if they've had a previous pneumothorax and they had a procedure to address recurring pneumothoraces, you could be seeing a site where the pleura is literally adhered to the chest wall, and it could look like there's no lung sliding. So it makes it a little trickier to evaluate for pneumothorax. And as we mentioned earlier, an unaerated lung due to an intubation into a main stem can cause nose lung sliding to be present. Again, in the clinical context of a young person with no past medical history, if they're in shock, acutely dyspneic, and you don't see lung sliding, this very likely could be a tension pneumothorax. And this is why it's important to practice a lot of your ultrasound so that when you have an abnormality, you can detect it quickly, because this is one of the scenarios where thoracic ultrasound can really shine and help you make a huge difference for your patients if you have a tension pneumothorax in front of you. So our last case is a 45-year-old male with a history of hypertension, coming for fever, chills, shortness of breath, and chest pain. He looks pretty uncomfortable. He's tachycardic, breathing a little bit fast. Blood pressure might be a little soft, especially given the fact that he has a history of hypertension, and he's setting 95% of room air, and he has a fever. So on the physical exam, he looks kind of ill-appearing. You're listening for breath sounds. You hear them bilaterally. Doesn't have JVD. The legs look fine. In terms of your differential diagnosis, I mean, he has risk factors. So for something potentially cardiac, given the chest pain? Could this be a clot in the lungs? Could this be ACS? This could be a pneumonia, it could be COVID, right? So again, our differentials, I mean, and I'm just talking about primarily pulmonary and cardiogenic causes. Obviously, there's multiple other etiologies that could be causing our patients to present the way they do. So, again, I want to impart that this general approach to thoracic ultrasound is just to kind of aid in simplifying or directing your treatment better. So you throw a probe on there and this is what you see. And this is only on the right side that you're seeing this. All right. So again, we discussed this artifact earlier. And on the base of the lung, you're seeing this finding. All right. So what is all this stuff? Again, you have B lines present, but this time for this patient is not on both sides, it's only on the one side. Again, you have your pleural line and this like vertical hyperechoic lines, laser-like, going all the way to the bottom of your screen. And on the base, you see this weird looking stuff above the diaphragm. That is called lung hepatization, which can be seen sometimes, not always, but it can be seen in really bad pneumonias. And it's essentially the lung parenchyma being filled with so much gunk in there from the infection that it can turn or appear more solid and hyperechoic, almost liver-like. And that's what hepatization stands for. All right, so again, thoracic ultrasound, just as good as CT for detecting pneumonia. Chest x-ray, not as sensitive. Some general scanning guidelines. You can start at the site of pleuritic pain. It's usually a unilateral process, and you can see dynamic air bronchograms. It's usually regional. You can see some hepatization. But not always, it's not always present. But in general, and I've personally had this happen, like literal one-sided B lines, and yeah, it turned out to be a pneumonia with an effusion on the one side that was affected. So again, a lot of the concepts that we're discussing today can be applied to multiple different pathologies. There's a bunch of research and data being gathered regarding COVID-19 patients. A lot of the artifacts that I have shown you today are seen in COVID-19 patients. So just take that knowledge that I've imparted on you today and kind of think about the clinical context of the patient. There are some general characteristics that we're seeing for COVID-19 in general, and this is not everybody reads the book, so this is not universal, but in general, they have bilateral lesions, and you're going to see bilateral B lines. In general, COVID-19 will not have a pleural effusion, so you will not expect to see a spine sign or fluid above the diaphragm. It tends to affect the lower lobes more frequently, and within those, the posterior lung is involved in the majority of cases. Again, a last little reminder, I would encourage you, whether you're a novice or an experienced user, to just practice and take a look at normal, because normal is so important to identify, because if you know what normal looks like, you'll be able to detect, okay, this looks a little strange, and you'll be able to, just improve the care of your patients. Ultimately, that's why we're all doing this. And this is more of a simplified protocol for evaluating. Again, pleural line with your linear probe in the parasternal regions, move it up between the third and sixth intercostal paces, just slide it up and down. And for the deeper lung parenchyma, you're gonna wanna use your phased array or abdominal probe in the parasternal regions and the lung bases to take a look and see if there's some fluid there. All right, thank you so much. And again, I'd like to remind you that we will be answering questions. So please put your questions either on YouTube or on Facebook, and we will have a panel at the end of the lecture to discuss questions that the users, the participants might have. All right, so thank you. The next lecture that we're going to have today is Dr. Michael Halperin. Dr. Halperin is an attending physician at Jacobi Medical Center at North Central Bronx. He's an assistant professor of emergency medicine, the Clinical Ultrasound Fellowship Director. Dr. Halperin.
Okay, are we live? Garvin Gray, if you can give me a thumbs up, my friend.
Yes, Dr. Halperin, you're good to go.
Okay. All right, welcome. My name is Mike Halperin. I'm the Emergency Ultrasound Fellowship Director at Jacobi in North Central Bronx in New York City. Super excited to talk to you guys today about shoulder ultrasound. Specifically, the point of this talk really is to get you excited about using ultrasound in the evaluation of suspected anterior dislocations. And to talk a little bit about, we'll segue into a little bit about the use of interarticular injections for anesthesia and reduction. At the end of the talk, I'm going to give you a next place to go if I have hooked your interest with this talk. So let's get going. Okay, here we've got a great little painting of a shoulder joint. And I really like this picture because the green is really what is going to translate over to our images on ultrasound. So here we see the humeral head articulating with the glenoid. And what I want you to take note of is that the glenoid really runs north-south, top to bottom, and that humeral head articulates laterally. So here's an X-ray of the same, and we'll keep talking about these same points, mostly the anatomy. So here you see the humeral head and the humeral head articulating with the glenoid. And one thing I want to make note of right from the start is this talk is not an argument against the use of X-ray. Really, this is a talk to try to build enthusiasm for the use of point-of-care ultrasound, potentially in addition to X-ray. But of note, there's about 4.8 billion people in this world who don't have access to advanced imaging. So maybe those who are thinking in their heads, X-ray versus ultrasound, maybe we can help reframe the question in a potentially different terms. Maybe it's ultrasound versus nothing, especially in the world of all kinds of really cool technologies with portable ultrasound devices. So let's get going. So in the point of care evaluation of the shoulder, the orientation is everything, and patient positioning is everything. So here we see one of my colleagues, Dr. Singh, approaching the shoulder from the posterior aspect, and you see the transducer in a horizontal orientation. You're going to want a transducer with a big footprint. And the point of that is because we're not looking for minutia. We're looking for big bones, the glenoid and the humeral head. So we want something with a big footprint. So for the rest of this talk, what you're going to see is images mostly of curvilinear transducers. If you don't have a curvilinear transducer, that's okay. But this talk is specifically going to show images of that transducer. Okay, so here you see again, the operator is on the posterior aspect of the shoulder. And so the horizontal orientation of the transducer is shining those ultrasound beams, if I may, posterior to anterior. And with a literal dynamic external rotation, you can see the humeral head nicely articulating with the glenoid. I think after the next 10 minutes or so, the anatomy will become fairly intuitive. So the footprint is posterior, and so moving down on the screen is anterior. This is medial, this is lateral. Another picture of the shoulder joint. Here we've got the humeral head articulating with the glenoid. This is normal physiology, there's no dislocation. And in an anterior dislocation, you're gonna see the anterior movement of your humeral head in relation to the glenoid. Similarly with a posterior dislocation, it moves backwards. Now, about 50% of all dislocations that present to the emergency department are going to be shoulder dislocations. And of those, about 97, 98%, depending on what source you look at, are going to be anterior dislocations. So really, the biggest bang for your buck is understanding normal anatomy on ultrasound and then understanding what an anterior dislocation looks like. Okay, all right, so I was just informed you're not seeing my cursor, so we are going to fix that from here on in. Okay, so here we've got one of our amazing interns, Dr. Liu, who remarkably is able to anteriorly dislocate his shoulder on command. No interns were harmed in the filming of this video. He does this pain-free, but I'm going to spend some extra time on this video because you weren't seeing my cursor previously. So the transducer is on the posterior aspect of Ben's back. So the top of the screen is his back. Those ultrasound beams, sound waves, shine posterior to anteriorly. So moving down on the screen is anterior. Again, posterior, anterior. Here we see scapular spine, glenoid, and the humeral head, which is moving from a position of anatomically correct to what an anterior dislocation looks like by moving down on the screen. So at the start of the clip, he's in the right place, and as the clip progresses, he's anteriorly dislocated. And again, Ben does this pain-free, cause no harm to our dear interns. Here is an anterior dislocation, not a dynamic exam like the previous slide, but the top of the screen again is posterior. The bottom of the screen is anterior. The humeral head is here. The glenoid is here. And you see this space, this is an anterior dislocation. So this is our joint space. Here's a good buddy of mine, Dr. Maninder Singh, showing the orientation, the setup of the operator. Again, is posterior to anterior with his curvilinear transducer in a horizontal plane. Posterior to anterior on Tom, this is one of our great nurses, on his shoulder. And on the screen here, you can see the scapular spine, glenoid, and humeral head. Okay, just a bit about the equipment that you're going to need for a potential intra-articular injection. The big point is this is full antiseptic technique. We're going into a joint space, so while the risk is low, we do need to be antiseptic in order to prevent potentially introducing any bacteria into that joint. The other point is longer needles, because the joint space is often deeper than you think it might be. This is part of the problem with or part of the argument for using ultrasound is to show that operator, especially the novice learner, just how deep into that shoulder they need to go in order to reach the joint space. Dr. Vinay, one of our great residents, just showing the setup for the introduction of the needle into the joint space, lateral to medial. And here's the full setup with the operator operating the ultrasound machine on the posterior aspect of Tom's shoulder, and then the needle going lateral to medial. And here we're going to see a little bit of I think this is probably the sweetest intra-articular injection I've ever seen. So again, let's just orient ourselves. Footprint is on the posterior aspect. Moving down on the screen is anterior. So here we've got scapula, glenoid, and humeral head. So our humeral head has now dropped down on the screen, which is anatomically anterior. So this is an anterior dislocation. And then moving lateral to medial into the joint space, you start to see the hyperechoic appearance of a needle. And on the next clip, what we see here is the introduction of anesthetic into the joint space, and you see the swirling around in this joint space. So that is a beautiful image of the anesthetic being deposited for pain relief. Okay, another argument for the addition of point of care ultrasound for the evaluation of the shoulder is you avoid all the woman and manpower necessary to do a conscious sedation for a shoulder reduction. So this is a patient that rolled into fast track, seen by Dr. Crystal, who demonstrates right away the utility of looking at the opposite side when we're talking about MSK ultrasound. And in this case, the shoulder is nicely shown on the unaffected side. And it's a great way to teach your learners prior to looking at the side that you know has some potential pathology. So here we see not a great view of the scapula, but you can see the humeral head articulating nicely. This is not a dislocation, as we didn't expect it to be. This is the unaffected side. To the right side, Dr. Crystal nicely and quickly, I hope you guys at home are now able to fairly quickly point out the anterior dislocation of the humeral head in relation to the glenoid. So again, we'll just keep hammering this. The transducer footprint is on patient's back. Moving down on the screen is moving anterior. So you see the humeral head has moved anteriorly down on the screen. This is lateral, this is medial. So in this next clip, you see Dr. Crystal nicely moving lateral to medial, not a perfect capture of the needle, but you see motion moving lateral to medial. What she's trying to do is get her needle in the joint space and deposit anesthetic. So what do we see here? Swirling anesthetic in the joint space. So I don't see the needle. However, we know we're in the right place because we see anesthetic swirling. The inline approach is difficult, and we are not arguing and saying that it's super easy and you're going to pick it up right away. It's worth practicing. It's challenging, and it'll translate to many other skills in point of care ultrasound and emergency medicine in general. But it is something that needs practice to improve upon. So Dr. Crystal injected the anesthetic, nicely done. Patient's got pain relief, and now the reduction can proceed. Shoulder is reduced, and post-reduction, we want to confirm, is that joint now reduced? There is a paper by Secco et al. In the Annals of Emergency Medicine that showed really good test characteristics for anterior dislocation, almost 100%. So our clinical question, is this shoulder now back in place? The answer is yes. Another picture of the setup. Here we've got Tom, one of our PAs over at North Central Bronx, showing the importance of the operator being able to see line of sight, setting yourself up ergonomically to be able to see patient and see screen in front of you, such that you're not bending and twisting and losing eyesight of your target. So the probe again is on the posterior aspect in a horizontal orientation, and potential intra-articular injection would be lateral to medial. Dr. Guha, one of our great residents, again, working in the emergency department, sees a patient that he's concerned for a dislocation, does the same thing that Dr. Crystal did, looked at the unaffected side to get a sense of the anatomy, what normal anatomy looks like. And here, a beautiful static clip. We've got scapular spine moving laterally to the glenoid. So the glenoid is moving up and down, not moving, but the glenoid runs up and down, and the humeral head is nicely in place, articulating with the glenoid. Posterior, anterior, medial, lateral. So this shoulder is anatomic normal. Now to the affected side, you see right away, the humeral head has now moved anteriorly down on the screen in relation to the glenoid. So another anterior dislocation. And I love that Secco et al. Paper from 2020 in the Annals of Emergency Medicine. The mean time to diagnosis of a dislocation was 19 seconds. So it doesn't take long to get a lot of information. Okay, so Dr. Guha here showing his intra-articular approach. His needle is already in the joint space. We don't see the deposit of anesthetic quite yet, but he is in the joint. You can see the needle in the joint. All right, another one of our residents, Dr. Tar here. Again, you don't see the approach of the needle lateral to medial, but what you do see is the anesthetic being deposited in the joint space, posterior aspect of the shoulder, moving anteriorly down the bottom of the screen, scapular spine, glenoid, humeral head, anterior dislocation with the anesthetic being deposited. Just a note of warning, what's happening here, this image looks a little different in how the anesthetic is swirling. It's because there's a little bit of air in the syringe. So just be very careful, get all that air out, because the injection of even the smallest amount of air will cause what's, sort of this dirty shadowing aspect or image of your ultrasound. It's gonna really mess up your view. So make sure you get all the air out of your syringe. Okay, just to talk about x-rays and ultrasound for a second. This is a young man, came in with pretty bad shoulder pain. X-ray shows no dislocation. He does, in fact, however, have a scapular fracture. So point of care ultrasound is great in answering our clinical questions. And if our clinical question is there a scapular fracture? This ultrasound image doesn't show you the scapula at all. So, and it makes sense because the ultrasound beam is really only going to show you what that beam is pointed at. And so if we're looking for shoulder dislocation, yes or no, great test characteristics. If we're looking for scapular fractures, pretty poor test characteristics. But again, let's just go over the anatomy. Posterior, anterior. This is the medial aspect, scapular spine, glenoid, and the humeral head. So no dislocation, but it's not showing us anything about the scapular fracture that this gentleman has. A dynamic exam of the same gentleman. Here you see the humeral head articulating with the glenoid. Another case, this is a humeral head fracture. You can see the disruption here. And this was maybe a week or two ago. I overheard one of our emergency medicine residents having a very polite conversation with the orthopedic consult. And the clinical question was, does this patient have a fracture dislocation? And so, again, remembering the 19-second median time it takes to diagnose a dislocation, ran over there and got this image. While not the most beautiful image, what you can see here is glenoid, humeral head, medial, lateral, posterior, anterior. There's no dislocation here. Okay, so if you guys can all take out your phones, or if you're interested, this is your next move. A great piece put together by two of our colleagues, Maninder and Vinay here at Jacobi and North Central Bronx. A great little step-by-step on how to diagnose dislocations, how to set up for the intra-articular injection. It's really well done, so I do recommend you take a peek at that. All right, guys, thank you very much.
Thank you, Dr. Halperin. Hello, Dr. Halpern.
What's going on?
I'm still seeing, so briefly, I'm just seeing the screen from the previous presentation still. All right, there we go. All right, thank you so much. All right, so moving right along, we're gonna have up next Dr. Gladstone Hackett. Dr. Hackett is an assistant professor of emergency medicine. He is currently practicing at the University of Texas Health Science Center. He's coming at us all the way from Houston, Texas. And he's going to be talking about an ultrasound that likely goes hand in hand with my topic, which is the lungs, which I would encourage you to do both of these together likely. He's going to be chatting to us about the focused cardiac ultrasound. Dr. Hackett.
Thank you, Dr. Montenegro. Can everybody hear me okay? Everything's good?
If we can hear you.
Excellent, thank you. We are going to. Just want to send all the warm vibes and everything to everybody up in the cold. Everyone from Jamaica and everybody from the West Indies and everybody from Houston, send some positive warmth up to our New York friends. So sorry. So my name is Gladstone. I'm from Houston. I've been here for a couple of years, so please forgive me if I say y'all a bunch of times. I do apologize. So I'm going to be talking to you today just about the basics of a cardiac ultrasound. It can be a really challenging, difficult topic to see. Hopefully I will try to kind of show you this is something that anybody can do, and it is basically simple if you can kind of remember that the heart has a lot of different types of anatomy than other parts of the body, but it's nothing that we can't accomplish and figure out with the help of our tool, the basic, the bedside ultrasound. So here we go. So objectives today, we're going to talk about, have a brief introduction, just talk about some of the indications of why we're doing our cardiac ultrasound in the emergency department. We're not cardiologists, we're not echo techs, we don't necessarily care about, you know, small things like trace tricuspid regurg and things like that. We're here to make big impacts in the time that your patient needs it the most. So we're gonna go over the anatomy, talk about how to get some good images and how the images should look, and things that you can do to augment it and make it look even better. We're not gonna talk about the abdominal aorta today, and that's about it. So introduction wise, why are we doing this? So we're looking for big things. So it sounds funny, but we need to know if in a cardiac arrest situation, is this person's heart actually beating? And that has a lot of implications depending on how you're going to treat your patient and what you're going to do next. So, you know, depending on the characteristics of what this patient came in like, you might be either pursuing and continuing this code, or you might just be saying, you know, we're going to leave it up to God's hands and it is time to call our time of death. Looking for pericardial effusion and tamponade. That's another kind of sexy topic that we like to talk about a lot. And, you know, when you should act on infusion and when you should not. One of the big things is also assessment of LV function. So that includes how good your squeeze is for your left heart. And also if there's any parts of your left heart that are not doing what they're supposed to be doing, like I'm getting that regional wall motion abnormalities in a kind of an ischemic situation. So one part of your heart's not getting enough blood flow. And we want to see that if that translates into a functional part of the heart, and we can use our ultrasound for that. Another thing that we use very, very frequently is assessment of volume status. Overall volume status, should we be giving this hypotensive person, should we be giving them fluid or should we not? Are we hurting them or are we not hurting them with our fluid? And how are they going to respond to those fluids? And then finally, sort of assessment of RV strain. We can talk about some of these other advanced things another time, but today we're just going to talk about the basics of how we're going to get these images and how can we answer these questions by getting some of our basic cardiac views. So that's what we're going to go over today. So just a brief, reminder, refresher course for us. we got 4 chambers, right? So we have 4 chambers that are doing a whole bunch of work, and they work together to act like the central part of our circulatory system. All right. So we got 2 atria. I'm gonna use my mouse here. Hopefully you guys can see this. We got 2 atria, left one and a right one. We've got 2 ventricles that do a majority of the work here. So the most anterior part of it, we're going to be showing this on some of the images that we're getting. The most anterior side of the heart is going to be our right heart. So our right atrium and our right ventricle. The big player is going to be the right ventricle. The left side of the heart is going to be more posterior. So your left ventricle and your left atrium. So they're going to take not necessarily a backseat, but they're going to be located posteriorly on most of our images here. And then apically, you're going to have your ventricles. They're going to be lateral to the left side of our bodies. And then more medially, it's kind of closer to the center of our chest. We're going to have our great vessels. We're going to have our atria up here. All right, so just kind of keep some of that stuff in mind. So we got 4 basic views. We've got our peristernal long axis, peristernal short axis, an apical 4-chamber view, which is the bane of lots and lots of people's existence, a subcostal view, and an IVC view. We're going to be using this guy over here. Ideally, this is the probe that you want to use. You can get away and use probably your wider footprint your wider footprint curvilinear probe. You can get away and use that in certain instances. But you really want to have the advantage of this probe, this phased array or cardiac probe that we have here on the right side. The big advantage of it is the size of the footprint is much, much smaller. And remember that our heart lives in our thoracic cavity in between a bunch of ribs. So what we want to do is be able to get in between those intercostal spaces and see as much as we possibly can. So really your best bet's going to be your phased array if you can. So we're going to go through all these views step by step. We're going to kind of use our little buddy here, the anatomical Netter's position. So this is an example on the right-hand side of what we want our image to look like. So have an idea of all these things, have an idea of what your image is supposed to look like, and do your best to kind of mimic that image. And I'll go over sort of some of the basics of how you get there. So you are going to orient your probe. So as the name implies, it's going to be peristernal. So remember that our heart is laying, I don't know if you can see this kind of like this, but our heart's laying kind of on a diagonal like this. So what we're going to want is we're going to be next to the sternum, right? Peristernal. And the long axis is going to go along that long axis of the heart. And what we're going to do is have our probe marker facing towards the patient's right shoulder over here. All right. And then if we can do that, we're going to have this image. Hopefully you're going to get an image that looks sort of like this on the right-hand side. So up at the top, remember that our most anterior chamber is going to be our right ventricle. And then as we go posteriorly, we're going to have our left ventricle right here. So this whole chamber right here is our left ventricle. Right ventricle is going to be on the top. That flappy kind of thin, not thin, but that thick walled thing in between there is going to be our interventricular septum. That's an important key player that we're going to be paying attention to later on. And then, so sort of towards our probe marker, remember we have our probe marker oriented towards, more towards medially, towards the patient's right shoulder. So therefore our great vessels and our atria are going to be towards our probe marker side, which is on this side of the screen. So this is going to be our left atrium. The right atrium is not really mentioned here. It's not really a great, not really viewed in this view. And then on the right side, you got the aortic view. The aortic root. So we can see our aortic valve opening up. And then at the very bottom, you want to make sure you set your depth deep enough so you can see this. This is called the descending thoracic aorta. So you want to make sure that your depth is deep enough so you can actually see this structure. This is also a really important structure in this view. So if we were to trace a drop of blood through here, we come in through our left atrium, through our mitral valve, which is this flappy thing between the left atrium and the left ventricle, in through here. The blood's going to then get squeezed back out through the aortic valve. Throughout the cardiac cycle, it's going to go through the aortic root, out through here, come around, arch down, and then come down to the descending thoracic aorta. and then eventually come back into the right side of the heart later. So that's our peristernal long axis view. So the short axis view is really, really similar to that. Oh, sorry, we're gonna keep talking about this, sorry about that. So here's what it looks like on an actual patient's chest wall. Again, our indicator is gonna face towards the patient's right shoulder up here. This is roughly where you wanna be, and we're getting these views like that. Now the short axis view, we stay planted, keep your probe planted exactly where you have your long axis view, because if you have a good peristernal long axis view, then you should be able to get a good peristernal short axis view as well. The only difference is we're gonna go from our long axis, that is taking our indicator and having it pointed towards the patient's right shoulder. Now what we wanna do is we're gonna slice the heart in half and have it pointed towards the patient's left shoulder instead. So it's gonna look kind of like this. This is gonna be the orientation of your probe. And you're really getting a nice cross-sectional view between your left ventricle here and your right ventricle out here. So again, your right side of your heart is gonna be anterior. So that's why we're seeing the right heart, the right ventricle up at the very top part of the image. And as we go down, here's that interventricular septum again. And here is all the cavity of the left ventricle. And then right in the middle of that, we can kind of see the mitral valve flapping around and getting pushed around by the different blood forces and stuff and pressure changes in the left ventricle throughout the cardiac cycle. So this is a good image to look at when you're comparing the right and left heart if you're worried about right ventricular strain. This is one of the views that we like to get. And you can kind of compare the right and left side together. So again, we got the right ventricle there, left ventricle right there. And then here's how it looks on the chest wall of the patient. The only difference between this and the long axis is that our indicators just rotated 90 degrees, just like any other view for bedside ultrasound. If you're looking for a longitudinal view and you're changing it to a short axis view, you're gonna rotate 90 degrees. So the heart's no different. All right, and here's the really tough one here, right? This is the apical 4-chamber view. So it took me a long time to be able to kind of master this, and even longer to be able to teach other people how to master this, but this is, it can be fairly simple if you kind of remember a couple of things here. So what we're gonna do is we're gonna go from our short axis view, and instead of being peristernally, instead of us being right next to the sternum and being centered, what we're gonna want is we want our indicator, our probe to live at the apex of the heart, hence the name apical 4-chamber view. So all we have to do is go from an upright view, let me change that around, an upright view of our heart. So we have our indicator facing towards the patient's left shoulder. And all we're gonna do is slide from this peristernal view. We're gonna go down laterally until we get to the apex. And as soon as we get there, we're gonna kind of flatten our probe out. So we're looking up into the patient's chest. So that's the idea, and that's where we wanna be. And it's gonna take some mental gymnastics to kind of figure out, how this view looks a little bit different, but it does make sense at the very end. So let's give it a shot. So we have our indicator facing towards the patient's left shoulder over here. So that means that everything that's on our this side of the view is going to be the left side of the heart. Everything that's over here is going to be the right side of the heart. But because we're coming from the apex, we're coming from the bottom part of the heart, our ventricles are going to be pictured at the top part of the screen, if that makes any sense. All right, so you got your left side here, your right side here, and these two are going to be your ventricular chambers. So you got your right ventricle over here, your left ventricle over here. And then because you're starting at the apex and moving medially, our atria are gonna be pictured at the bottom part of the screen. So here you got your right atrium and your left atrium right here. And then in between, of course, you got your two AV valves, your right AV valve or your tricuspid valve and your left AV valve or the mitral valve, all right? So that's kind of the image that we're gonna have here. And I really wish I was down there with everybody so we could kind of practice this and everybody get a chance and get their hands on the probes, but hopefully the Rona will let us be together soon again. So here's, again, just labeling the same thing that we already talked about: left atrium, left ventricle, right atrium. All right, and here's how it kind of looks on the chest. Again, we're not doing that kind of perpendicular view where you're right on the chest like this for our two peristernal views. You're actually kind of laying the probe down and you're looking up into the chest like that. So that's kind of pictured here. And if you're having trouble still, one thing that you can do is have the patient, if they're able to, have the patient kind of roll over and lay on their left-hand side, the lateral decubitous view. And what that'll do is help your heart swing a little bit more anteriorly and therefore closer to your chest wall so you can get a better view. So if you're having trouble, try to think about rolling your patient to the left. Last view of the heart is going to be the subcostal view. And I just want to remind everybody that the reason that we have all these different views of the heart is that some people, not everybody's heart is going to be perfect and pristine. And everyone's going to have different pathologies that are going to make different views easier or more difficult. So some people might have, for whatever reason, might have a difficult view of all your peristernal and your apical views, but sometimes they might have a really great subcostal view. We want to be able to answer those questions in the time that is most valuable to the patient. We want to be able to get the information. And if we can't, get the view, then it's kind of not a really good service to our patients. So you want to be able to kind of master all these different views. So let's press on. This one's called the subcostal view. We're going to have our indicator. If you're in cardiac mode, you're going to have your indicator facing towards the patient's left, actually, which is different than if you're in the abdominal view. If you're in the abdominal mode setting on your ultrasound, you want to have the probe flipped and you want to have your indicator facing towards the patient's right side. But this is a cardiac lecture. We're going to talk like cardiologists today. So your indicator is going to be faced right to the patient's left-hand side. And you're going to get right up underneath the subcostal view, right up underneath the xiphoid process of the sternum. And you're looking up through the liver, which is this guy right here. You're going to be using the liver like to kind of augment your view. And you're going to be looking up through the liver and in towards the heart this way. And when we do that, so the first thing you're going to see at the top, because our footprint of the probe is closer to the liver, the first thing you're going to see is the liver. And that's a telltale sign of which view you're using when you're going through. So we have the liver here. Then the first chamber and the biggest chamber we're going to see is still going to be the right ventricle. And because our indicator is facing towards the patient's left-hand side, all the, which is right over here, all the chambers that are going to be on the right side of the screen are going to be on the left side. So these are actually going to be your ventricles. But remember that your right ventricle is going to be the most anterior one. So therefore, that's going to be the top one, the first one you're going to encounter. And then you're going to encounter the left ventricle on the other side down here. All right. And then away from your probe marker, that's closer to midline, which is where our atria live, then you're going to have your smaller chambers, your two atria. But again, remember that the right side is going to be more anterior than the left side. So therefore, the first one you're going to see is going to be your right atrium, followed by your left atrium, going to be more posteriorly. All right. So this is a really good view for people who come in who have had cardiac arrest already, and they may have been getting chest compressions for the past, I don't know, however long, 30 minutes, hour, however much it is. They've gotten some chest compressions. Sometimes if you're doing really, really good chest compressions, you crack a couple of ribs and therefore pop a few lungs. And so therefore your peristernal views might not be so great. They might not be as good because you get kind of leakage of air into the subcutaneous tissue and into your chest wall, and therefore you can't see anything peristernally up here. That is for our other previous views we talked about, the peristernal long, the peristernal short. So this is a really good one because there's no air theoretically to pop. That shouldn't obstruct your view when you're down there. And also, you're not getting in the way of chest compressions, ongoing chest compressions, if you're looking for a subcostal view because you're way down here. Chest compressions should be kind of occurring up here more. And then finally, we want to see our, okay, so again, this is just a kind of real life view. having our indicator facing towards the patient's left side. Keep in mind that you're actually holding the probe overhand, and the reason why is because you want to flatten out as best you can so you can actually get underneath your ribs and aim towards the heart on this side right here. So notice this person is holding the probe overhanded, unlike some of the other views that we did before. All right, and finally, the IVC. All right, so we want to see is this bad boy right here. The view that we'd like to see is having the IVC dump directly into the right atrium of the heart, and we want to get a nice longitudinal view of the IVC. And this gives us a good example of a good idea of how good this patient's volume status is, what kind of shock they might be incurring, which is a whole other lecture we could talk about another time. So how do we look at it though, and how do we get a good view of it is we take our probe, whichever one we're using, and we're gonna have our indicator facing downwards towards the patient's feet. And we wanna be able to, again, get that nice longitudinal view of the IVC dumping directly into the right atrium. So in order to do that, we're just gonna pop it right there, kind of similar area as we did for the subcostal view, and just have the indicator facing down south. And we're gonna get a view that looks kind of like this on the side. We're gonna be going through the liver, so that's gonna be the top part of the view. And we're gonna have our IVC right here. And on the left side of the screen, you're gonna have the heart or the right atrium. I want you to also pay attention to this thin-walled vessel right here. This is called the hepatic vein, and that's how you make sure that you're dealing with the IVC and not actually having a view of the aorta itself. You can kind of make misrepresentations of the patient's volume status if you're not looking at the right vessel. All right, so another just live action view of what it looks like, having our indicator facing towards the patient's feet. All right, so I hope you guys got a little bit out of this and demystified how complicated the cardiac ultrasound can be. Feel free to send me any questions later on. Thank you. Let me get out of here and stop sharing my screen.
Thank you, Dr. Hackett, for that awesome lecture. All right, so before we move on to the remainder of our program today, I'd like to make a few announcements. One is that we have troubleshooted. If you're a participant and you're interested in receiving a CME certificate by email, I encourage you to click on the link and fill out your information so you can get your certificate emailed within the next few weeks. And I'd like to talk a little bit about the foundation that has essentially made this event possible today. I'm going to read briefly something about the Jaja Foundation. So Jaja stands for Jamaicans Abroad, Helping Jamaicans at Home. Again, it was founded by Dr. Trevor Dixon. The Jaja Foundation is a nonprofit organization that has been participating in the upliftment of Jamaica since 2007. The foundation seeks to support the Jamaican diaspora and friends of Jamaica all around the world. They concentrate their philanthropic efforts in areas of health, social services, and education through partnerships with Jamaica's public hospitals, schools, and communities. Again, we're going through some difficult times with the pandemic, but their work has not stopped. And we're going to provide a link if you're interested in donating to the foundation and all the great work that they're doing in collaboration with institutions in Jamaica. We have their website, which is www.jajafoundation.org. That's JAHJAH foundation.org. And there will be a link available on YouTube and Facebook if you're interested in donating to us. So moving on, next up, we have Dr. Jeffrey Kim. Dr. Kim, I had the pleasure of doing residency with. He's a graduate of Jacobi Medical Center, and he's currently an attending physician at Palmetto General Hospital in Florida. He's going to be talking to us about gallbladder ultrasound today. Dr. Kim.
Hello, everyone. Can you guys see my slides?
Yep, we can see your slides and hear you.
All right. All right, so I'm going to go over to gallbladder ultrasound. My name is Jeffrey Kim. I apologize if my internet is a little funny. I'm actually in Ecuador right now, but here it is. So reasons to use gallbladder ultrasound. Any clinical suspicion for biliary colic, cholecystitis, choledocholithiasis, or cholangitis. Patients can present with abdominal pain. We're classically taught that it presents with right upper quadrant pain, but keep in mind that I've seen many patients with epigastric or flank pain. This is because of the fact that the gallbladder is a mobile structure and people's anatomy is different. It could also present as painless jaundice, for example, in pancreatic cancer, or with fever and sepsis without any pain. A common scenario that we often see is nursing home patients who are septic, elderly, their exam is unreliable, and in certain cases, you could have very severe acute cholecystitis that leads to gangrenous or necrotic gallbladder. And in those cases, you might not have any pain. Just to kind of quickly review the structures that we're most interested in ultrasound for the gallbladder is the gallbladder itself, the cystic duct, which connects the gallbladder to the rest of the biliary tree, as well as the common bile duct, which where the cystic duct and the hepatic ducts connect. And the pathologies that we're interested in is anything that causes an obstruction within the biliary duct system, whether it's a common bile duct or the cystic duct. Here we could see gallstones. You could also have biliary sludge in the case of acalculous cholecystitis, or any external forces, such as pancreatic cancer, that leads to elevated pressures in the biliary duct system. So how good is ultrasound? This slide has a lot of values. I don't want you to memorize these values, but it's always good to have a sense of the sensitivity and the specificity values of the ultrasound study to get a sense of how to best utilize the ultrasound. So in general, for cholelithiasis or for gallstones, as well as for cholecystitis, gallbladder ultrasound is excellent in ruling out the disease. For common bile duct stones, the sensitivity is only around 70%, so it's actually not perfect. You might rely on your exam or lab values such as your AST, ALT, or indirect bilirubin to get a better sense of whether or not there is disease within the common bile duct. And always keep in mind that ultrasound is actually the study of choice as opposed to CAT scan. CAT scan and ruling out acute cholecystitis, the sensitivity is only around 40%, so it's not that great. So again, this is how I interpret these, all that information, all those values. In ruling out gallstones, ultrasound is excellent. In ruling out cholecystitis, it's very good, not perfect. For ruling out cholelithiasis or cholangitis, it's only okay. And again, oftentimes I'll also rely on the lab values. And CAT scan is actually pretty terrible at ruling out biliary disease. So the probes you use when you perform ultrasound, you have the curvilinear probe as well as the cardiac probe. You could use either one of these. And to identify the gallbladder, the first view that we're looking at is the transverse view up here. And you have the probe inferior to the costal margin, just right to the midline. And again, the indicator is to the patient's right. And when you scan up and down, the gallbladder looks like a big circular sac right here. The second view is the longitudinal view, and the probe indicator is towards the patient's head, and you scan to the right and left. Here we have the gallbladder in the longitudinal view, and in this general vicinity is the portal triad. The largest structure is the hepatic vein, is what you're seeing right over here. Sometimes the ribs can get in the way of identifying the gallbladder. So one of the things that we could do is take advantage of the fact that the gallbladder is a mobile structure, and you could sort of get the gallbladder out of the way from the ribs. And you could do this by adjusting your patient's position. You could do the left lateral decubitus position, have the patient turn to the left side, and the gallbladder sort of just plops out away from the view of the ribs. Or you could have the patient sit up, like in this case. A common pitfall in identifying the gallbladder is pretty much any fluid-filled structure can appear to look like the gallbladder. It's going to look like a black circular structure. The most common pitfall and the most common structure that's confused with gallbladder is the IVC, because the IVC is adjacent to the gallbladder. Here we see a transverse view, and this is the gallbladder, this is the IVC, and this is the longitudinal view. The gallbladder, here's the portal triad, the portal vein over here, and this is actually the IVC. And as you can see, it's right next to each other and it could be easily confused. So one way to differentiate between the two is taking advantage of the fact that the gallbladder has no blood flow through it, whereas the IVC or the aorta has blood flow through it. And you could use a color Doppler to differentiate. And clearly we see, blood flow through the vessels and no blood flow through the gallbladder. And now to the more interesting portion of the lecture, the pathology. Here we see gallbladder stones. And a gallbladder stone is identified because it's hyperechoic or it's very bright in structure with black shadowing behind it. You could have either these large gallstones, like over here on the left, or a bunch of tiny gallstones, like over here on the right. And again, it's going to be a hyperechoic or a bright structure with shadowing or black behind it. And a pitfall is you could confuse a polyp for gallstones. The big thing is, again, there's going to be shadowing behind gallstones. And here we see a polyp. It's a bright structure similar to a gallstone, but again, there's no shadowing behind it. And for cholecystitis, or an infection of the gallbladder, there are 4 findings that we're looking for. The first is sonographic Murphy's sign, which is basically you put the probe right on the gallbladder and you push down. And if it's tender, that's a sonographic Murphy's sign. It's actually the most sensitive finding, so the best way to rule out disease. But again, keep in mind that in elderly patients or in gangrenous gallbladder and severe cholecystitis, you might not elicit the pain. The second finding is pericholecystic fluid. Here on the top right, we see an illustration of that. You see all this like black surrounding fluid around the gallbladder. The third finding is anterior wall thickening, and anything that is more than 3 millimeters is unusual. So over here, we see a measurement of the anterior wall. The measurement that they're giving us is about 3.3 millimeters, so that's anterior wall thickening. And it's very important for you to measure the anterior wall, not the posterior wall. So the anterior wall is anything closer to the patient's chest wall or the stomach. Because in the posterior wall, you could have layered gallstones, which could make the posterior wall appear thicker. So you could falsely measure the posterior wall. And the fourth sign is what's called the Sin sign, or the stone in the neck of the gallbladder. And here we see a large stone in the neck of the gallbladder. And this is because the neck of the gallbladder is adjacent to the cystic duct. So any stone that's, sort of lodged in there could lead to an obstruction. So how do we diagnose cholecystitis? I gave you all 4 of the findings that we're looking for. But sometimes and oftentimes you don't find those findings. And again, remember the specificity and the sensitivity for cholecystitis is not perfect. Some facts to remember that could kind of help you in your study is that acalculous cholecystitis is very rare. Or so typically you're going to see gallstones. So if you don't see any gallstones, that could lower your suspicion. The most sensitive finding is the sonographic Murphy's sign. And again, I went over, the fact that elderly patients or necrotic gallbladder, you might not elicit the pain. And just keep in mind that every additional finding of, the cholecystitis findings raises the specificity and the positive predictive value of the disease. So my approach is, if I don't see any gallstones, my suspicion for cholecystitis is lower. If I don't elicit pain with my sonographic Murphy's, it's probably not cholecystitis. But again, I look at the patient. If they're young and they're, pretty with it, my exam is pretty reliable. But if they're elderly, they're nursing home, they've had many strokes in the past and they're nonverbal, the exam is less reliable. So if I do have a sonographic Murphy's, it's cholecystitis until proven otherwise. So cholecystitis is possible. And any additional finding that I find, whether it's anterior wall thickening or stone in the neck of the gallbladder or pericholcystic fluid, in addition to the sonographic Murphy's, I'm definitely thinking this is cholecystitis. And for the last portion, I'm going to go over identifying the common bile duct. This is always sort of the hardest part in doing the gallbladder study. It's something that I struggled with initially when I was learning this exam. So the big things to remember are the contents of the portal triad. The common bile duct runs along with the portal vein and the portal artery, as illustrated over here on the left. And if you take a cross section of all 3, this is what it's going to look like on ultrasound. So remember, the first thing you got to remember is the contents of the portal triad. The second thing to remember is that the portal vein is the largest structure in the portal triad. And over here, we see, the longitudinal view on the ultrasound. You have the gallbladder, you have the portal vein, and by remembering that all 3 of those structures of the biliary triad, they run together, and that the portal vein is the largest structure, you could approximate the location of the common bile duct, which is often very small, by first identifying the portal vein. And over here, the portal triad sort of looks like Mickey Mouse. So we call this the Mickey Mouse sign. With the face of Mickey Mouse being the portal vein, the largest structure, and the ears being made up by the common bile duct as well as the hepatic artery. And to identify, there's going to be 3 steps when you do the ultrasound. First is you take the longitudinal view, you find the gallbladder, and you find the portal vein. It's the largest structure of the portal triad. So we call this the exclamation point sign. The gallbladder essentially directs us straight to the portal triad or the hepatic vein. Then we zoom in on this structure, the portal vein, and we can see the Mickey Mouse sign or the portal triad. And lastly, we take advantage of the fact that there's no blood flow through the common bile duct. So again, we're going to use color Doppler flow to differentiate between the three structures. And you have the hepatic vein, the largest structure over here. And this appears to be the hepatic artery. And again, there's no blood flow through the common bile duct. So this must be the common bile duct. And here's an ultrasound to illustrate this. Again, this is the gallbladder pointing us straight to the pleural triad, the exclamation point. Here we have the three structures of the pleural triad. We have the hepatic vein, which is the largest structure, the hepatic artery, and the common bile duct. And again, we're using flow to differentiate the three. And in order to sort of get a sense of whether or not there's any type of common bile duct obstruction, any type of stone in there, what we're doing is we're measuring the intraluminal diameter. So the diameter inside of the common bile duct. So after we identify the common bile duct, we measure the space in between. There's some controversy over which value to use. A common one we see is anything more than 7 millimeters. Or anything more than 6 millimeters plus 1 millimeter per decade after 60 years. And this is because with age, your common bile duct actually expands over time. So anyone who is 70 years old, that will be anything greater than 70 or 7 millimeters. Anyone 80 years old, anything more than 8 millimeters. The way that I approach this is anything between 7 to 10 millimeters, I'm highly suspicious that there's some type of gallbladder stone going on or choledocholithiasis. And anything more than 10, I definitely know that there's something going on. And in this illustration, it looks like this is the measurement of the common bile duct. And the measurement is around 19 millimeters. And I think that's it.
Thank you, Dr. Kim. That was an awesome lecture. Before we move on, I'd like to thank everybody that's tuning in with us today. The team worked super hard, and I think ultimately all of us, I'm pretty sure, share the sentiment that we're hoping to inspire, if you're a novice user, if you're an experienced user, to continue to teach and learn new things, and just, again, encourage you to take all the information that you're learning today and use it clinically, use it on your stable patients so that when you have that sick patient, you can make a huge difference in their care. I also want to acknowledge our media sponsors again, Ras Clem of Grooven Radio, WVIP FM 93.5, Dervan Malcolm and the team at Power 106 Jamaica, who again have always supported the foundation's initiatives, and Mr. Erwin Clare and Irie Jam Radio. Thank you so much. So next, we have Dr. Simone French. She's the medical director at the University of the West Indies. She's an emergency medicine consultant and a trained sonographer. She's going to be presenting a few awesome cases along with a cohort of her residents at the University of West Indies. Dr. French.
Okay, morning, everyone.
can hear you, Dr. French.
Okay, great. Morning. Thank you so much to the organizers of this 13th Annual Emergency Medicine Conference for inviting the team at the University Hospital to participate in the conference. This morning, we're going to be sharing with you a few of the cases that we have seen, just a few, and it will actually incorporate a lot of what you have heard before and give a more clinical approach to how we incorporate these things into patient management. This is my hospital, the University Hospital of the West Indies, the Emergency Medicine Division. And this is one of 4 sites across the Caribbean at which emergency medicine is offered as part of the UWI Emergency Medicine Program. And you see here some of my colleagues. The pandemic, I'm sure it has hit many of you hard, and we're all working hard, and it's very easy to focus on the difficulties, but here we see several of our colleagues receiving sweet treats and other things provided by those who really appreciate our efforts. So the journey to ultrasound here at the DM Emergency Medicine Program really began with interest that I developed as a resident in the Emergency Medicine Program. This led me to enroll in a sonography program, an 18-month course, and then I used those skills to incorporate the teaching of point-of-care ultrasound into our graduate program in emergency medicine. Subsequently, our local emergency medicine association, the Jamaica Emergency Medicine Association, began offering courses annually so that we could extend skills in point-of-care ultrasound to our colleagues at other hospitals across the island. And these were very successful. Our most recent triumph is that we have been able to incorporate the teaching of point-of-care skills to our 4th-year medical students when they rotate with us in the emergency department. And this has been quite a success. We focus on the teaching of fast ultrasound because with our current resources, that's as much as we can teach them, but we're hoping to extend those offerings in years to come. So today you're going to hear from some of our residents in the program and a recent graduate. First up, we'll have Dr. Fairclough, a first-year emergency medicine resident who you've actually met in the presentation because he was actually in the promotional video that was shown as he has attended one of the Jaja Foundation ultrasound courses. He'll be followed by Dr. Janelle Yu, one of our 2nd-year emergency medicine residents, and Dr. Camille Rainford, a recent graduate, will round out the presentation. She is currently a chief resident here with us at Mona in the emergency department. Like church, our presentations will run concurrently, and we will take questions. When you post them in the chat, we can take the questions in the question and answer session that will follow. So with no further ado, here's Dr. Fairclough.
Good morning. I'm Dr. Fairclough, coming to you from warm Jamaica. So this brings us to case 1, right, of patient AD, a 56-year-old female who presented to the University Hospital of the West Indies. She's known to be hypertensive and has been on medication for 20 years for same, but is non-compliant. She actually presented multiple times for what was described as central chest pain and was told that her serology, ECG, her radiological investigations were unremarkable. And she was sent home a diagnosis of gastroesophageal disease. When she presented to the University Hospital at triage, her vitals were normal except for hypertension at 139/99. And she was triaged to an emergency severity index of 3. An ECG was also ordered and it was again found to be normal. She described the pain as pressing in character, transcending severity, radiating from the central chest to the mid to lower back, and she also had associated right lower limb pain. Pertinent negatives were that she didn't complain of any palpitations, she had no shortness of breath, no fever, no cough. However, while in the emergency room, she started to have hypertensive episodes. And as you can see in the slide, as high as 225 or 124. So a 4-limb BP was ordered, and there was a noted discrepancy in the lower limbs, with the right lower limb being 83/57, and you can compare it to the left lower limb. In literature, interlimb BP discrepancies of greater than or equal to 20 millimeters of mercury is concerning for aortic dissection. So a point of care ultrasound was done. So what you're seeing here is what we expect to see if the person has an aortic dissection. So you're scanning the person in the midline, patient line supine, from proximal to distal, right? Starting at the xiphoid process. And what you'll expect to see on horizontal and transverse axes are depicted here. So above in this video, what you're seeing is the aorta, and you can see a intimal flap, right? Which would be indicative of an aortic dissection. Just for orientation, there's also the IVC, and you can also see the spine. In the horizontal axis, you're also looking for the aorta, and it's important to see the celiac trunk, which is the first division of the abdominal aorta. And you're also seeing the superior mesenteric artery. So in our patient, when we scanned her, of importance, we noted that she actually had an aneurysmal abdominal aorta. And the widest diameter, which is from the outer diameter of the aorta to the other side, is 3.54 centimeters, or what 3.54. And normal would be less than 3 centimeters for the abdominal aorta. So this video highlights the intimal flap, which you're seeing as this hyperechoic mobile structure, right here. And you're also seeing the collapsed inferior vena cava and the spine posteriorly as stated before. So ideally, you should attempt to trace from the celiac bifurcation down to the common iliac arteries. However, it may be difficult because with transabdominal echocardiogram, what you notice is that bowel shadowing, or what we call dirty shadowing, from bowel air can make it difficult. And as we know, the aorta is retroperitoneal, right? So a transesophageal echocardiogram may be useful, and in combination, this increases sensitivity of findings of an aortic dissection. So this is the longitudinal view. Well, it's a little oblique, but you can see the intimal flap here in the aorta, which would also be indicative of an aortic dissection. And I think you can also note the first branch of the aorta as well, abdominal aorta, that is. So for completion, you should get a cardiac view. So what we did was a subxiphoid pericardial window view. And this is necessary because you want to rule out if the person has a pericardial effusion or a cardiac tamponade. And Dr. Hackett did mention this in his presentation. So in our patient, what we found on subxiphoid view, so you're seeing right ventricle, left ventricle, and you can see the right atrium here, the septum, and the liver is above, right? And this was negative for pericardial effusion, and a pericardial effusion would heighten your suspicion of an ascending aortic dissection with the appropriate clinical scenario, of course. And there was no signs of cardiac tamponade. Contractility looked well and looked normal. So a study that was recently done in 2020 in China by Wang et al., they found that POCUS compared to CT aortogram had 100% specificity and 86.4 sensitivity, as it missed more commonly Stanford B dissections. And they also noted a reduced door to diagnosis time and a door to treatment time, which will be pertinent because the mortality for dissection increases with time, right? So gold standard, as we know, is a CT aortogram. So one was actually done, and what you can see here is the descending aorta, ascending aorta. You can see the intimal flap here, right? And you can see the true lumen, false lumen. Okay, and this is the liver coming into view, the stomach, the bowel, the spleen, and we're going all the way down to the bifurcation. All right, so the kidney is coming into view here, and if you continue to trace, you can see that in the right, that the aortic dissection continues down in the right common iliac artery. So while the patient was in hospital, interestingly, day one, she was obviously diagnosed with a Stanford B dissection, and she got conservative management by the medical team. She was placed on labetalol prior to getting the CTA based on the findings of the POCUS ultrasound, and she actually maxed out the labetalol infusion before reaching target mean arterial pressure. She started to complain of a sore throat in the emergency room, and she was actually found to be COVID positive on the confirmatory test, the PCR. She was transferred to the isolation unit, and while there, she had severe abdominal pain, and there was a concern if she had multi-organ necrosis. She was referred to this cardiothoracic team, and they actually rescanned her to see if there was any extension of the dissection, and it was confirmed again as Stanford B aortic dissection. Now, she spent 14 days up until the point her PCR COVID was negative, and she was sent home for outpatient clinical follow-up, and she remains well up to today. So just some information. So the incidence of thoracic aortic dissection is approximately 3 per 100,000 persons per year. And because of the high mortality and the elusive nature of dissections, it is grossly underestimated. So this may not be a true number. And 38% of patients are missed on initial presentation. So with that said, right, is there a relationship between COVID-19, which is a hot topic now, and aortic dissection? So in literature, what was found that with viral illnesses, you can have direct cardiac manifestations due to direct infiltration and cellular damage. So reported are person can get acute pericarditis, a left ventricular dysfunction leading to heart failure, cardiac arrest, acute coronary syndrome, myocardial infarctions, and thromboembolic events. I found one single case report of a patient, a 47-year-old female, who had no chronic illnesses, but she came with respiratory symptoms. And on day 8, she was actually diagnosed with a Stanford A dissection, right? And actually she demised on day 8 after the diagnosis before they could take her to theater. So this is pertinent because the literature does state that there's an increase in aortic dissections in the winter months and also with influenza A and B, but there's no obvious correlation as yet between COVID-19 and aortic dissections, but it's not very far-fetched. So this is not a coronavirus symposium, so we'll continue. So this case highlights the usefulness of POCUS in the emergency medicine department for diagnosed and expeditious treatment of patients with confirmed aortic dissection. A CT and aortogram should always be ordered, however, but POCUS may decrease the wait time and increase the treatment and management, well, decrease the treatment and management time and therefore save a life. All right. Thank you, everybody. Now I'll hand over to Dr. Hugh.
Hi, good afternoon, everybody. I'm Dr. Hugh, and I will be presenting case 2. So this is the case of Miss JR, a 53-year-old female who presented to the emergency room with a generalized itching to the body for 2 weeks. She was not known to have any chronic illnesses and gave a 2-week history of generalized itching to the body that was associated with epigastric discomfort radiating to the chest. She also admitted to vomiting undigested foods for 10 days prior to presentation, with weight loss secondary to this vomiting, a 5-day history of Pepsi-colored urine, and a 4-day history of yellowing to the eyes. She denied any change in the color of her stool, any associated fevers, myalgias, arthralgias, or exposure to any rats. Her vital signs were normal except her elevated blood pressure of 143/86. She was noted to be mildly icteric, and her abdomen was soft and tender in the epigastric region, but she had no guarding, no rebound, or masses felt. So we assessed her as having obstructive jaundice. The plan for Ms. JR was to do a bedside ultrasound, as her history and examination sparked my interest to perform this ultrasound. And we did other lab investigations, such as her complete blood count, her urea and electrolytes, her liver function test, her amylase and lipase. We also did a formal ultrasound to confirm our bedside ultrasound findings. And she had a urine analysis done that only showed leukocytes 2+. As we review her labs, we can see highlighted in red are her abnormal findings. And we see that the bilirubin and the transaminases were noted to be abnormal, and her other lab investigations were normal. This is an ultrasound of Ms. JR's gallbladder. And here we see an anechoic structure representing her gallbladder with multiple hypoechoic foci within it. And this demonstrates the posterior acoustic shadowing. So here are these hyperechoic foci, the anechoic structure, which is the gallbladder, and we see the posterior acoustic shadowing being demonstrated by the gallstones. Of note, a maneuver that we can do is to actually turn the patient on their side and visualize these hyperechoic structures moving with the changing position. And this is what we call the rolling stone sign. And essentially what this is to do is to differentiate a gallbladder mass from stones. Here in this image, we see the right lobe of the liver, and we see multiple dilated intrahepatic ducts within the liver. And here the arrow is pointing at our common bile duct. As was mentioned before, color Doppler can be applied to highlight vascular structures and confirm structures which are avascular, which in this case would represent the bile ducts. So here we see our avascular structures in which no color Doppler is being highlighted. The formal ultrasound report demonstrated cholelithiasis with mild intrahepatic duct dilatation. However, there was no evidence of acute cholecystitis, which was in keeping with our bedside ultrasound. The patient was seen by the general surgery team and given a date for clinic and a request to do an MRCP. The patient's clinical course included an MRCP that actually showed a hilar mass with ductal obstruction, portal vein encasement, and gastric outlet obstruction. These features suggested a central cholangiocarcinoma, specifically a Klatskin tumor, and cholelithiasis was again made note of. She represented to the accident and emergency room 2 months later with a history of worsening weakness, abdominal pain, and vomiting since initial presentation. And she was assessed in the emergency room as having gastric outlet obstruction, secondary to her likely obstructing cholangiocarcinoma and severe dehydration with acute kidney injury. Her chest, abdomen, and pelvis was done on day 14 of admission, and these findings were in keeping with her MRCP and showed no evidence of distal metastasis. She had an upper GI endoscopy done on day 16, and note was made that the scope was unable to pass the pyloric outlet, and there was extensive distal gastric involvement by the tumor. Recommendations made was that her biopsies of her stomach and her pyloric area should be followed up, and she should have a surgical gastric bypass. By day 21, she did have her surgical gastric bypass, and intraoperative findings included a hard tumor involving the porta hepatis, the hepatogastric ligament, and the head of the pancreas. Note was also made of a distended gallbladder filled with multiple stones, and the neck of the gallbladder was involved in the tumor. To date, she's actually still admitted to the ward. So as mentioned before, when doing a focused gallbladder ultrasound, it should be done in 2 views. We should ideally have the patient in the lateral decubitus position as seen in the image above here. And this is done in order to use the liver as a window and to displace the bowel. The most common indication for doing a focused ultrasound of the gallbladder in the ED is usually to diagnose acute cholecystitis. And we should do the longitudinal image as seen here and an axial image as seen in this image below. And what the features that we'd look for acute cholecystitis, which was mentioned, is our presence of cholelithiasis with the posterior acoustic shadowing, our sonographic Murphy's sign, and our gallbladder wall thickening of greater than 3 millimeters, and the presence of pericholecystic fluid. The most sensitive ultrasound finding in acute cholecystitis is the presence of cholelithiasis in combination with maximal tenderness over the sonographically localized gallbladder, which is known as our Murphy's sign. And in one study of 497 patients, Riles et al. Showed this combination of findings to have a positive predictive value of 92%. So as our patient presented with obstructive jaundice, we should go through some of the differentials for obstructive jaundice. And this can be either intrinsic or mural causes versus our extrinsic causes. And some of our intrinsic causes include our choledocholithiasis or cholangiocarcinoma or sclerosing cholangitis or biliary strictures, just to name a few. And for extrinsic causes, we have cancers of the gallbladder, the head of the pancreas, metastatic cancers, gallstone pancreatitis, and periductal adenopathy. This is not an exhaustive list, this is just a few differentials. But just to make note that our patient's cause was likely the cholangiocarcinoma. So this study, titled Sonographic Evaluation of Obstructive Jaundice by Gamardin, was done in 2015, and it showed that there was an association between the cause and age with increased prevalence of obstructive jaundice with increasing age, and that the major sonographic feature of obstructive jaundice was actually dilatation of the intra and hepatic biliary ducts, and that obstructive jaundice was more common in females than males, and that the most common causes of obstructive jaundice were gallstones at 54.1%, followed by abdominal masses at 32.67%. And this correlated with our patient, Miss JR, who was both female, had features of intrahepatic duct dilatation, and had both gallstones and an abdominal mass. However, the likely cause of her obstructive jaundice was her cholangiocarcinoma. So just to remember, there is more to the gallbladder than just acute cholecystitis. The history and clinical presentation of the patient can clue you into the diagnosis of what the cause of the obstructive jaundice may be, and that your findings may easily be supported by your ultrasound, which is easily accessible at the bedside. However, additional imaging modalities will be necessary to ascertain a cause. Thank you. And now Dr. Rainford will be doing case 3.
Good afternoon, everyone. I'm Dr. Rainford. So case 3, MS is a 65-year-old male who presented to the emergency department with a 2-week history of gradual painless loss of vision to the right eye. Vision loss commenced on the outer aspects of the right visual field and gradually progressed inwards with progressive vision loss. Patient is known to wear glasses at baseline, and his comorbidities include hypertension, benign prostatic hyperplasia, and glaucoma, for which he is maintained on topical agents. On presentation, his vital signs were unremarkable, with the exception of the blood pressure, which was elevated. Visual acuity was restricted to hand movements in the right eye, and it improved to 2200 with glasses. The next step was to examine his pupils, which were found to be equal and reactive to light. I then proceeded to perform a fundoscopic exam. However, this proved to be difficult in an undilated eye. So what to do now? So the next step was to really do an ocular ultrasound. So this slide here, it may be new to some persons, for other persons it may be a review slide, but basically an ocular ultrasound is performed at the bedside using a linear high frequency probe, and to the closed eyelid, a thick layer of ultrasound gel is placed over the eye. Special care must be made to ensure that pressure is not exerted on the globe. So when doing the ocular ultrasound, there are numerous structures that can be seen in the eye, and we're going to be moving from outside inwards. So we're able to see the closed eyelid, followed by the cornea, also the anterior chamber of the eye. This thick hyperechoic structure here is the iris. We're also able to see the convex lens, and this large anechoic structure is a vitreous humor. And posteriorly, we're able to see this hyperechoic structure of the retina. Now, the retina is responsible for the vision of the eye, and the area of sharpest vision in the eye is actually the macula. The macula is located in an area that is just adjacent to the optic nerve. So here is a shadow of the optic nerve, and it basically appears as a tail that is entering the globe of the eye. So the macula is located just lateral to the optic nerve. So now we look at the actual pictures of the patient. So here we can see the anechoic structure of the vitreous humor, and here is a thick hyperechoic structure consistent with a retinal detachment. And with motion, it actually has a serpentine motion. This is just another view of the retinal detachment. So in this video right here, we're basically demonstrating a principle that is called kinetic echography. So in this maneuver, the patient is asked to move the eye from right to left and also up and down. And basically what it does is that it helps us to see this thick, serpentine motion of the retinal detachment, but we're also able to see the extent of the retinal detachment. So as mentioned previously, the macula is in an area that is just lateral to the optic nerve. So here is the optic nerve in the diagram, and we can see that the retinal detachment extends past that area of the macula. So basically the patient has a right retinal detachment and the macula is off. This patient was referred to the ophthalmology service. On review by ophthalmology, they basically concurred with the findings of the ocular ultrasound. And they also noted that the patient had some areas of lateral degeneration. And these are basically areas of abnormal retinal thickening that predisposes a patient to having a retinal detachment. These areas of lattice degeneration were found in the affected eye as well as a contralateral eye. Patient was advised to return to the hospital the following day for consultant review. However, he defaulted from follow-up. So I put this slide here. It's basically an image for the textbooks. A lot of us, when we go to medical school and we do the ophthalmology rotation, we have this expectation that if we're viewing a retinal detachment, we'll see this nice sheet of, pale retina lifting from the posterior aspect of the eye. However, for a lot of us, it proves to be difficult when we're doing an ophthalmic examination. So here we have a study that was done. Basically what they did was that they evaluated 329 emergency physicians, and they basically asked them, how comfortable are you performing an ophthalmic exam? And what they found was that 50.6% of the participants said that they felt comfortable performing the exam, and another 57% felt that they felt comfortable communicating the findings to their colleagues in ophthalmology. So what these findings suggest is that definitely emergency physicians and doctors as a whole, we do have an issue when we're doing the ophthalmic exam. So a good alternative for us would be to use an ocular ultrasound. So an emergency physician performed ocular ultrasound to detect retinal detachment was found to have a sensitivity between 91 to 100% and specificity between 83 and 100% as documented in the literature. Furthermore, this slide was basically here, and basically for the ultrasound enthusiast, you'll find that if you want to be a little bit more, better at, identifying the retinal detachment, you can apply the color Doppler technology to your ocular ultrasound. And basically the retinal vessels, the retina consists of retinal vessels, and they would be highlighted on color Doppler ultrasound. And this is a useful technique that can be used to differentiate a retinal detachment from other ocular pathologies. Ocular ultrasound has also proven to be beneficial in evaluating vitreous hemorrhages and posterior vitreous detachment in the emergency department. So on ocular ultrasound, a vitreous hemorrhage will appear as a snow globe appearance, whereas a vitreous detachment, it would appear as a thin hyperechoic structure, and it would have a swaying seaweed appearance. Of note, both of these pathologies can be confused with a retinal detachment. However, on color Doppler technology, there will be no arterial flow with these pathologies. There's also the concept of macula on versus macula off. And we can recall that the index case had a macula off retinal detachment. So basically, what is the current trend within the ophthalmology spheres is that a macula on retinal detachment is one that is more emergent, as it is more vision threatening, and the aim is to limit the extension of the detachment and to preserve the vision as much as possible. Whereas a macula off detachment, the surgery can be delayed for up to 10 days without impairing final visual outcomes. So it's just something for us to think about. So next time you're evaluating a patient in the ED with an ocular pathology, don't hesitate. Pick up your ultrasound probe and you might be surprised at what you might find. So that ends my presentation. Thank you. I'll now hand over to the moderator.
Thank you so much to the residents at the University of West Indies. Thank you for those excellent presentations. I would just like to echo in our private attending chat for all the participants that are talking here, that we're really impressed with all the cases that you're discussing right now. Awesome presentations. And I can't imagine, I've been in your shoes, how exciting it is to throw a probe on there and actually find pathologies that significantly impact your management of a patient. These are excellent cases. Thank you so much. So next up, we have Dr. Roger Shirley. He's a resident currently at Kingston Public Hospital, and he will be talking about traumatic pneumothorax.
Okay, thank you, Dr. Montenegro. Just checking if my video and my audio is good.
Yep, we can hear you and we can see your screen.
Thank you so much. Good morning again, everyone. My name is Roger Shirley. I'm one of the medical residents here at the Kingston Public Hospital, Accident and Emergency Department. And this morning, I'll just be going through a case, what we saw in our accident and emergency, the case of the traumatic pneumothorax. So let's go. So we saw a 60-year-old man that presented to our accident and emergency department in December 2020. He was involved in a motor vehicle accident. About 30 minutes prior to presentation, the history that we got from the bystander was that he was sitting on the sidewalk when he was hit by a truck, unfortunately. So he had a history of loss of consciousness, but he regained consciousness upon presentation to our department. When he arrived, he complained about shortness of breath and he had severe left-sided chest pain. He had no history of vomiting, but he did report that he had some bleeding from the nose. There was nothing of significance in his past medical history, nor was there anything of significance in his personal history. So we began our management as per ATLS guidelines, starting with our primary survey. We checked his airway, it was clear or patent, and we made sure to secure his C-spine using a rigid C-collar. Of note, there was no abnormality detected. There was no posterior midline tenderness nor any step deformity noted. But when we looked at his breathing, we realized that he was in trouble here. So he appeared dyspneic, right? Initially, his respiratory rate that we got initially moved from 20 quickly up to 24 breaths per minute. His trachea was not deviated, but we were able to palpate bilateral rib fractures. There was also some deformity and tenderness and palpation of the right clavicle, and there was subcutaneous emphysema along the left anterior lateral chest wall. His air entry that we checked was decreased bilaterally, but more so prominent on the left side with some crepitations. And his SpO2, which was 97% initially on room air, soon fell to 90% on room air. So we initiated oxygen therapy by face mask. Just quickly looking at the rest of the primary survey that we did, there was no major site of bleeding except for laceration to the forehead. He had no distended neck veins, but he was tachycardic at 113 to 114 beats per minute. His blood pressure was 103/66. In terms of his GCS, he was 15/15, but as I said before, he had loss of consciousness and he was undressed but covered and he remained normothermic in the accident and emergency department. Other findings that were significant, he had epistaxis from the right nasal cavity and his abdomen was non-distended but had some mild generalized tenderness with no guarding. So we started our management with the EFAST. When we looked at his abdomen, there was no free fluid appreciated. When we looked at the pericardial, or in the pericardium, there was no collection. However, when we looked at his chest now, we saw the absence of lung sliding or pleural sliding with the barcode sign noted on the left hemothorax. So we thought that he had a left pneumothorax. So in this video right here, I'm showing the right hemithorax in B mode, which is the unaffected side. Note that he complained about severe left-sided chest pain. So as our previous presenters had shown us, there's adequate lung sliding here shown at the right hemithorax. But when we look at the left hemithorax, the affected side, if you can see, there is no lung sliding appreciated. in B mode. Hope everyone can appreciate that. So there's no lung sliding, no shimmering of the pleural line. So we also looked at M mode of the right hemithorax, which was the unaffected side. And here we're seeing bright shimmering on the pleural line. So there's adequate lung sliding here, and this is the unaffected side, right? But if we look down at the bottom right here, we're actually seeing that seashore sign. So we can able to see the waves indicated up here, and also the seashore right here. So that's in a normal lung where we'll see the seashore sign, and this is the unaffected side. But when we look at the left hemithorax, which is the affected side, in N mode, we're able to see that classic barcode sign. So again, if you look at the top right here, we have the basically showing the B mode, right? There's no lung sliding. And when we look at the bottom showing the M mode, right? We see that classical barcode sign, like barcode you get at what you see on the products at the supermarket. So this is affected side, and this is the side that we thought he had a left pneumothorax on. And also, as Dr. Montenegro had pointed out in her presentation, we see the lung point, right? So here we're seeing on the right side of the screen where we have that sliding of the lung. But however, when you take a look on the left side of the lung, we're seeing that junction where there's sliding and non-sliding. So this is where we conclude this is where our lung point was, and it was very specific for a pneumothorax, left-sided pneumothorax. So what did we do? He was quickly consented for a left tube thoracostomy, and we inserted the tube on the aseptic techniques in the left fifth intercostal space, anterior to the mid-axillary line under local anesthetics and local anesthesia, and it was connected to an underwater seal. We got adequate oscillations in our underwater seal, and it drained approximately 100 mils of blood. So quickly after we replaced the tube, we repeated these vital signs, and we saw that his blood pressure came up 117/80, still tachycardic at 118, his respiratory rate had falling to 20 breaths per minute, and his SpO2 was now 98% on supplemental oxygen. So we sent our patient for check x-rays. Significantly, his chest x-ray revealed the chest tube that was in situ adequately placed. He had partially re-expanding of the left lung, right? He had left subcutaneous emphysema that we could have visualized, and the right clavicular fracture that was displaced, as we mentioned before. So here's a picture showing his chest x-ray, right? It's not probably clear for a lot of people, but let me try to highlight these. So our red circle right here attempts to highlight the presence of the right clavicular fracture, right? Our yellow arrow points directly to our placed thoracostomy tube. Our green lines attempt to highlight the presence of the rib fractures, which may not be clear to everybody, right? And our dotted blue lines attempts to highlight the subcutaneous ear emphysema noted on the left. So the patient was consulted by the general surgeon and the neurosurgery team, and he was admitted to the general surgery ward for multidisciplinary care. So this is another patient that we actually saw in our accident and emergency department. So here we have a young male who was a victim of gunshot wounds to the right chest, as you can see right here. So we're seeing a few puncture wounds to the right chest. And basically I'm going to show a video of us doing the ultrasound real time. So as I said, the patient is here on the bed. Gunshot was noted to the right hemithorax. And when we look at the ultrasound, right, on the right chest, right, we're seeing absence of lung sliding. But when we compare to the left side of the chest right now, we're seeing adequate sliding of the lung. You see that shimmering on the pleural line. And go back to the right chest, still no lung sliding. Okay. And just another case, right? We had another young man, unfortunately, that was stabbed to the right upper chest, right? This video basically shows the left side, which is the unaffected side, showing that nice shimmering along the pleural line, no lung sliding in B mode. When we look at his right affected side where he was stabbed, there was no lung sliding in B mode, absolutely still on that pleural line. When we look at his M mode, right, and we look at the left side, which was the unaffected side, we see that nice seashore sign that we're talking about. And then we look at his affected side where he was stabbed, right? Where we're going to see that barcode sign in M mode, or it's sometimes called the stratosphere sign. So just a little broader slide that we had. So a very interesting case that we saw recently. This was actually a 14-week gestation and abdominal pregnancy. This lady came in with abdominal pain, and there was that baby floating around in her abdomen. And another slide. Shout out to Dr. Hackett for going over cardiac ultrasound. This was actually another trauma patient that we had, gunshot wound to the chest, transthoracic, went through the pericardial cavity, but fortunately spared the heart. So thank you for your time. I hope you guys enjoyed the presentation and learned something. Shout out to Dr. Tawana Jones for giving me the opportunity to do her case. Over to you, Dr. Montenegro. Thank you.
Thank you so much, Dr. Shirley, for that excellent presentation. Those are awesome cases. Again, thank you to all the residents. I hope if you're tuning in and you're a medical student or a resident just starting out or an attending physician, you can appreciate how useful point-of-care ultrasound can be as you're evaluating a patient. Something to keep in mind is that ultrasound, sonography in general is like a whole universe. We, as emergency medicine practitioners, are focused on certain clinical questions as we're scanning our patients. To that effect, there is core ultrasound proficiency that's expected of emergency practitioners. The American Society for Emergency Physicians has put out like a core ultrasound content list that you can check out in ASAP's website. And with that in mind, Dr. Sonnenthal created a handbook which provides you a breakdown of the core ultrasound studies that are expected of emergency physicians or if you're working in any acute setting. And we have the handbook available in PDF, in iBooks, in multiple e-formats or digital formats. I'm going to give you 2 email addresses for the participants if you're interested in obtaining a copy of this handbook. First will be the email for the Jaja Foundation. That's info@jahfoundation.org. If you have any questions or are interested in potentially getting the handbook, you can reach out to them, or you can email Dr. Sonnenthal directly. Her Gmail is necama.sonenthal@gmail.com. Thank you again for all the presenters. These cases are super interesting and very inspiring, always. So next up, we have none other than Dr. Trevor Dixon. I mean, we've spoken and heard of him during these sessions. Again, he's the CEO and founder of the Jaja Foundation. He's an emergency medicine attending at Jacobi Medical Center, and he's the director of ultrasound at Jacobi Medical Center. Also a trained sonographer, so an excellent resource. And he's going to be giving us a super useful talk on first trimester ultrasound. Dr. Dixon.
So good morning, everyone. Am I live?
Yep, we can hear you, Dr. Dixon, and we can see your presentation on the screen.
Okay, I'm going to do a short abbreviated version of first trimester emergency ultrasound obviously for the pregnant patient. Just want to say briefly that This is not a first trimester ultrasound from the obstetric and gynecological point of view. We're basically have a small peephole look into the world of obstetric and gynecology. And basically the indication for ultrasound for us is basically a female that comes in presenting, complaining of abdominal pain and or vaginal bleeding. The first thing we want to do is obtain a urine pregnancy test to see if the patient is pregnant, yes or no, because that will change our algorithm rather quickly. Once we discover that the patient is pregnant, we're going to perform a bedside point of care ultrasound, and we're basically looking for the intrauterine pregnancy, the IUP. Once we find an IUP, that patient can, if the IUP is deemed to be in the right location in the uterus, that patient can be discharged in about 1 hour from presentation into the emergency room. At that point, if they have vaginal bleeding, the only thing we will be waiting for is the RA status. Otherwise, from that, we would just abdominal pain, we can discharge the patient home, knowing that the pregnancy is in the right place, or look for another cause for the patient having pain and not really suspecting ectopic pregnancy. That patient can be discharged home. And the reason why this is important, because traditionally, before point of care or point of care ultrasound or bedside ultrasound was initiated by emergency physicians, we would have to wait for patient's serum beta HCG, which means it has to go to the laboratory and it can take hours before it comes back, depending on the labs at your institution. At that point, we have to call the radiologist and tell them that the beta HCG is 500 or 1,000 or 5,000. And then that radiologist would decide if he deemed it necessary to call the sonographer. And sometimes that was a cumbersome conversation where they'll say to you like, well, the beta is only 100 or the beta is only 50. Do we need to call the tech, especially at nighttime? Do we need to call the sonographer in at night? And as you know, as many of you may know, that a beta of 50 or a beta of 2,000 doesn't mean that it is or is not an ectopic pregnancy. So beta is really not very useful when we do an emergency medicine. The urine pregnancy test being positive or negative is more useful. So the study is performed by the sonographer, who takes about 2 hours to come into the institution at night to do the exam. So this can take anywhere from 3 hours to 6 hours to 8 hours, depending on your institution. And many of you guys know what I'm talking about. So our dilemma all starts when a female comes in the emergency room and says, I think I'm pregnant or I'm pregnant. They did a home pregnancy test and it came back positive, and now they're presented with abdominal pain or vaginal bleeding. And we know this is a graph here showing the correlation of the beta HCG and the weeks here at the bottom. And pretty much in the emergency room, this is basically useless to us. We need to know, is the patient pregnant, yes or no, and we would perform our bedside ultrasound to see if there are certain key factors that makes us have a high suspicion for ectopic pregnancy. There is a phenomenon out there called the discriminatory zone. Basically, it tells you at what level beta HCG and what you would see on the bedside ultrasound. And as you can see, a gestational sac should be visible by a beta of 1,200 to 2,000. And we should see a fetal pole with a probably yolk sac by 10 to 20,000 units of beta HCG, and cardiac activity, which you see when the beta HCG is greater than 20,000. And I must say that this varies from laboratory to laboratory, these numbers, and also it depends on if you're doing transabdominal versus transvaginal. If you're doing transvaginal, the resolution is much better, and the numbers that you see intrauterine pregnancy will be much lower, just because of the better resolution. So this is where our problem first starts. This is an electron microscope depiction of an early implantation. And this looks like a great image, right? The resolution is obviously best right here on the electron microscope. But the problem is we don't know where exactly this pregnancy is. Is it in the fallopian tube? Is it in the cervix, implanted in the cervix? Or is it in the abdomen? So we use bedside ultrasound to give us a better idea where this pregnancy is located. And as you know, the female anatomy is very, very simple. We have the uterus in the middle, and we have the adnexa or the ovaries on both sides, and it's pretty much depicted just like you see it here on the human body. That is absolutely incorrect. The human body, the woman's body, doesn't adhere to any of those things you see in an anatomy textbook. This is a cadaver depiction of the ovaries. And as you know, just like how the women have rights, the ovaries have the right to be anywhere in the pelvis that they choose to be. And they usually exercise that right, which makes it very challenging for us to scan the adnexa and get a good depiction of where the ovaries are. So ovaries are very challenging to see. The uterus is very challenging to see. And why is it so challenging? First off, let me say that the ultrasound, as we use it in emergency room and critical care ultrasound, is non-harmful to the growing fetus. And the reason why, because as emergency physicians, we don't scan for longer than 5 to 10 grand, at most 15 minutes. And that will prove no harm to the growing fetus. What do we like to use to scan the first trimester pregnancy? We like to use a curved array, which is depicted at the bottom of the screen here. This is a curved array. The megahertz or the frequency is usually about 2.5 to 3.5 megahertz. And ideally, you like to have the patient have a full bladder. And we know in emergency medicine, our patients' bladder are never full because the first thing we tell them to do when they come into the emergency room is we need a urine sample. So the women's usually sometimes they have to wait on the ladies' room. And by the time they come back to the bedside, their bladder is empty. So this is where our challenge begins. And these are the obstacles that prevent us from getting that nice resolution image that you may see in the radiologist's office. They tell them to go fill their bladder and the women wait there until their bladder is full when they feel like they're almost ready to pee. We don't have that luxury in emergency medicine. So we're always working on the suboptimal conditions. And the reason why it becomes challenging is because if you look here, this is intestines. And putting the probe in the pelvis where you would normally see the early pregnancy, you'll see that the appendix is here and the bowel is obstructing your view of the uterus. And also the bladder, which would traditionally be full with urine, is now empty. So our window has just disappeared for getting the best image possible. However, the good thing about the human body is that it knows that we need ultrasound in emergency medicine. So it always leaves a little bit of fluid in the bladder. The bladder is usually never completely empty, or if it is empty, by the time we get around to scanning them after they've peed, we have about, looks like about 200 cc's of fluid, and we can get a general idea of where things are in the uterus. This is the vaginal canal, this is the cervix, and this is the fundus of the uterus in the bladder that's not full. And you can see here, we're looking at a yolk sac, which is the first sign of a normal implantation for our ACEP guideline. Here's an ideally full bladder. Here's a vaginal canal, cervix, fundus of the uterus, and the metrial echo. This is bowel displaced here, and the rectum would be located posteriorly, ideally. Another image of the uterus, posterior cul-de-sac, cervix, vaginal canal. The abdominal contents would be located here. A full bladder pushes the abdominal contents, the intestines away, and the uterus comes in to give you a nice, beautiful picture. We never get these ideal pictures in ultrasound, emergency ultrasound, because our patients are usually just peed, as I said, or their bladder is not full. Just want you to know that the uterus can have varying appearance. Here's a null parity uterus, so it varies from patient to patient. Here's a transabdominal view and a transverse view of the uterus. Here's the anterior wall of the uterus, and here's the posterior cul-de-sac where free fluid would be collected. So this is what we ideally like to see in emergency room to send a patient home. We like to see the uterus here, the bladder as our guide to see we're in the right location, vaginal canal, cervix, and this is what's called a yolk sac. And this yolk sac is the first sign of a normal intrauterine pregnancy. And that's the ACEP guideline. Why do I say this is our first sign of a normal intrauterine pregnancy? The reason why I make that distinction is because radiologists, as you know, they have a different criteria than we have in emergency medicine. Radiologists believe that once they see a decidual basalis or a decidual capillaris, once they see a sign of an early pregnancy, they don't wait for a yolk sac to to call it a normal intrauterine pregnancy. And the reason why they don't wait for a yolk sac, because they're doing a lot more scans. They're looking in the adnexa, they're looking in the posterior. They do a lot much more comprehensive look into the woman's pelvis or the uterus before they make a decision that this is a normal uh, implantation. Our criteria is going to be different. And if we look at the uterus and we can't see what's inside the uterus, or we only see a gestational sac, the next step for us is to do what's called endovaginal scanning. If you don't have this capability of doing endovaginal scanning at your facility, it's probably wise at that point to have the patient have a comprehensive ultrasound in the Department of Radiology, because our job in emergency medicine and critical care is not to find ectopic pregnancy. Our job is to rule in a normal implantations. And I know sometimes a lot of practitioners, they'll take a chance because they don't see anything in the uterus. They can obviously guess and say, well, I think this patient is not having ectopic pregnancy because she's not been having pain at this time. But I would caution you not to be so sure, because there are patients who present with no pain sometimes, just vaginal bleeding, and they do have ectopic pregnancy. So basically with endovaginal scanning, you're going to put the probe, or aim to put the probe, in the anterior fornix right here, and it'll give you a beautiful view of the uterus, and the resolution will be a lot better than transabdominal because you're that much closer to the uterus. And ideally, you want to have a full empty bladder for the transvaginal scanning. As you can see here, the bladder is anterior and superior on your screen. We'll take a look at what it looks like on ultrasound. Here it is. Here's the bladder. Here's the uterus. Here's the endometrial echo or endometrial stripe. Here's the posterior cul-de-sac, and this is all bowel around surrounding it. Here's another image here depicting in the vaginal scan. You can tell by the semicircle. Here is the uterus. The vaginal canal will be coming this way, cervix, fundus. Here's an endometrial echo or endometrial stripe. And this is something in the posterior cul-de-sac. And Dr. Halpern and I, we always say that free fluid is not always free, in the sense that sometimes free fluid typically would appear black, but it can, based on the stage of clotting of blood, you have to be mindful that clotted blood have more heterogeneous, and it doesn't typically look black. So you have to be mindful of that as you scan. Excuse me. Yeah. This slide is very important, and we presented this slide to let you understand that there are certain criterias. Scanning the pelvis can be very tricky at first, and it can be very dangerous. So there are certain guidelines that have been put in place to make sure that we can identify without a doubt when the implantation is actually in the uterus and not in the fallopian tubes. Sometimes a novice practitioner can see a pregnancy within the fallopian tube and think it's within the uterus. So there's a theory, there's a concept called the measurement of the myometrial mantle. And myometrial mantle measurement is a distance from the tip of the endocavity here to the myometrium here. So this is where the implantation is. You measure the distance from the tip of the endometrium here to the tip of the myometrium, and that should be greater than 8 millimeters. And why 8 millimeters? Because after measuring many fallopian tubes and measuring many uterus, it is deemed that most fallopian tubes are not going to be greater than 8 millimeters, even when it has edematous and debris within it. So a myometrial mantle measurement is very important to demonstrate, to show that the pregnancy is you're actually measuring the uterus and you're not measuring something in the fallopian tube. Here's a close-up view of the fetus and the yolk sac. This is the yolk sac here, the first early placenta, so to speak, and this is the fetus here. And this is important when you're trying to measure the early pregnancy. You don't want to measure the yolk sac with the fetal pole. So this is the first image I'm going to show you, and I want you guys to take a look and tell me what do you think is going on. Sorry. Okay, so this is as far as I'm going to give you. So I will tell you that this is an ectopic pregnancy. And there are certain criteria here that makes you know that this is an ectopic pregnancy. And one of the first criteria to let you know it's an ectopic pregnancy is this located right here, which is what's called a pseudogestational sac. It almost looks like a normal sac, as you can see. But if you do miss that, you should not miss what's going on here behind the uterus. Here's a globule or some kind of a heterogeneous material, and that's actually clotted blood. So this is the first image I'm going to show you of an ectopic pregnancy. We're going to look at some others in a few seconds. And here we have the same patient here. You can see that there's something located behind this is the uterus here. And this is off to the left on the screen on the uterus. And this is a pregnancy within the tube. And if you measure the distance from here to here, you would see that you're not in the uterus. The uterus is over here. And this is the nexal region. And you see that there's actually looks like there's a fetal pole in here, or a fetus here, next to the artery here. This is near the ovary, the nexa, and you're actually measuring an ectopic pregnancy. So you have to be mindful of where you're measuring your IUP, and everyone's going to have a different view of what they see within the uterus. I understand at 3 o'clock in the morning, it's almost time to go home. The patient comes in, she's pregnant, she's having abdominal pain, vaginal bleeding. She may or may not be, on her phones, texting her loved ones, telling them I'm in the emergency room. So we can be deceived by patient's presentation. Not every patient who's having an ectopic pregnancy will come in hypertensive or tachycardic. That's actually a very late sign. And as emergency physicians, we don't want to be what's called behind the 8 ball. We want to be early in these diagnoses so we can get the necessary help we need to manage these patients and ultimately save their lives. So here's another depiction here. And the purpose of this image is to demonstrate that I'm looking at this image right here. We put the circle here. So this circle, the patient didn't come with an actual circle around her and her uterus. So we have an area here within the gestational sac, and 50% of the people who are viewing this image will see that there's a yolk sac in here, and there's another 50% who are not sure if this is a yolk sac or if they're seeing correctly. And this is normal in emergency medicine. If you're not sure if you've seen a yolk sac or not, don't send that patient home. Have them have a comprehensive studies. There'll be lots of cases where you'll see a normal yolk sac with a fetal pole for you to take a chance with a patient's life if you're not sure if this is a yolk sac. Depending on how much experience you have scanning, you may be able to determine that this is a yolk sac with possibly echo dropout here, which means based on the ultrasound beam, you're not seeing a complete circle here. So every practitioner is going to be different, and you just want to be practicing in a safe manner. I have to reiterate this slide here, showing the myometrial mantle, the distance from the endometrium to the tip of the myometrium, and this should be greater than 8 millimeter. This one is actually 1.5 or 15 millimeters or 1.5 centimeters. So this is safe to say this is the uterus and not a fallopian tube. And this is very important. So basically, I'm going to talk about a quick case of a 35-year-old female who came in with crampy abdominal pain, and her last menstrual period was about 2 months ago, and her beta HCG was 4,000. First question we should ask ourselves is, what do you expect to see? And I always have a picture in my head with a beta 4,000. I would think I'm going to see an early implantation. I'm going to see the baby waving to me saying hi. I'm going to see the yolk sac. And we always have a mental picture based on the discriminatory zone, which I discussed before, of what we are hoping to see in this female. And this is what we actually see. This is a transabdominal scan. This is the bladder. Here is the looks like the vaginal canal here, and here is the uterus. And what do you see here? We see the uterus here, and we see all this other stuff posteriorly here. So we said to me, man, God, this doesn't look normal. Let me get another view and another angle. This is longitudinal. Let me get a transverse view. So I put the probe in transverse, and here is my bladder. Here's my vaginal canal. Here's my uterus in transverse, and here's all this stuff. What's called smuts that's around the uterus here. Here's the vaginal canal going up to the fundus, and we see all this debris here. Fresh blood, clotted blood, because these patients, they come in. This patient in particular was on her phone texting away. She didn't have any pain when she presented to us at that point, laying in the bed, and she was texting her loved one saying, "Hey, I'm in the emergency room. I'm having some, I was having some pain, so I just came in to get it checked out." And she was totally stable. And she had, this is a ruptured ectopic pregnancy we were looking at here. See all the debris here, blood, uterus in transverse, cervix going up to the fundus in transverse, and all this clotted blood around there. This is the kind of patient that you don't want to assume that she's doing fine because she looks fine. You want to actually be able to perform the ultrasound and be able to make a decision from there. Here's another interesting slide. Here's a patient that came in also complaining of abdominal pain. Her blood pressure was 98 over somewhere 50, and most of our young females, they're not hypertensive. They're 25, 26 years old. Their blood pressures they live around 100, 105, 110, 99 sometimes. And we're seeing them in the emergency room. They're talking. They've been having this pain for a couple of days, and you'd be surprised to know how much fluid the pelvis can hold before patients become symptomatic. Here is the uterus here, here, and this is all clotted blood here. Clotted blood here. There you go. And clotted blood anterior and clotted blood posterior. This is a patient who should have been in the OR hours ago, and is sitting in the emergency room chilling, thinking that everything's okay. And we tell her, you have to go to the OR now because you have massive amount of fluid. The GYN residents came down and they were able to identify and see it, and they prepped and got this patient ready for the OR right away. This is the difference that point of care ultrasound will make for your patient. Here's another view of that same patient, clotted blood. Here's the uterus here, clotted blood. It looks like a nexa, looks like an ovary here, and all this clotted blood. As you notice here, we haven't seen one ectopic pregnancy yet. I don't even look for the fetus at this point. There's enough in this view to tell me that this patient needs to go to the OR. If you spend your time trying to find the ectopic pregnancy, you're way out of your scope and you shouldn't be doing this. This is free fluid here. This patient should be going to the OR. So remember, folks, when patient comes in presenting with abdominal pain, don't assume that that pain is just suprapubic pain from a UTI. Do the pregnancy test early and find out, is this patient at risk for an ectopic pregnancy? Here's another transvaginal view. Here's free fluid. That's just typically black. And just remember, free fluid is not always free or looking black. It can have a very complex look. And when you're scanning a patient who comes in suspecting abdominal pain, you should always scan the right upper quadrant, because free fluid is transient, and it will travel throughout the abdomen. So if you scan the right upper quadrant in a patient that's laying supine, you will see free fluid at the tip of the liver and the area of concern called in Morrison's pouch. So every patient who comes in with abdominal pain, whether you find a pregnancy test or not, if you're waiting for the pregnancy test, always do a right upper quadrant scan. Make sure there's not any free fluid, because if there's free fluid in there, to heighten your suspicions, you can get the surgeons cued and the OBGYN doctors cued. And then based on the urine sample, we can follow the algorithm that will point us in the right direction. Beware of a pregnant patient with abdominal pain and or vaginal bleeding. Always measure the myometrial mantle. Urine pregnancy test is going to help you to delineate which way you want to go. Don't always wait for the beta HCG to put the probe down and figure out what's going on with this patient. And if you suspect the ectopic pregnancy, always scan the right upper quadrant, and always trust your patients and their account of pain. If you see an IUP and the patient still has pain out of proportion, there's something else going on. Don't send that patient home. And that concludes my talk, and I thank you for your time. Yeah.
Thank you. Thank you, Dr. Dixon, for that excellent lecture. Always super helpful and very useful to know this study, especially working in the emergency room. So I just want to remind, or first thank everybody that's tuning in right now with us. We hope that we've inspired you to integrate ultrasound in your clinical work. And I want to remind, if you're tuning in, that the Jaja Foundation, through which we're organizing this conference today, is still very much active, even though we live in strange times right now with the pandemic. They are involved in fundraiser efforts. They're fundraising right now to purchase ambulances to take to Jamaica. They have training programs for clinicians in Jamaica. They work with training clinicians in ultrasound and other things in Jamaica's public hospitals. They do HIV awareness and prevention. They also are involved in multiple public health efforts. And if you're interested in donating to their cause, we have a website, www.jajafoundation.org. You can go there and check out and read more about the amazing activities that they do in Jamaica. And also, if you can donate, anything helps. And next and last, we will have one of our very own residents, Dr. Ani Ramachandran. He's a PGY2 emergency medicine resident. He has taken the initiative to integrate a new type of nerve block into our department. And he's done amazing work collaborating with not only emergency, but anesthesiology and the trauma team to get this project off the ground. And we will be doing this nerve block in the coming months. And he's just going to talk to you about the nerve block itself for hip fractures. Dr. Ramachandran.
Okay. Thank you, Michelle. Just want to see, are you able to see the PowerPoint?
We can hear you and we can see your presentation.
Okay, thank you. So thank you guys for having me. My name is Ani. I'm a second-year emergency medicine resident here at Jacobi. I wanted to talk to you guys about the pericapsular nerve group block, otherwise called the PING block for hip fractures. Couple things we'll be talking about today. Essentially what it is, why it's important, what we know about it so far, how do we do it, what are some complications or things you should be aware of. A little talk about a model that we've created and our proposal here to start implementing this block here at Jacobi. Before we get started, I just wanted to talk a little bit about my motivation. This was on November 15th, 2020. This is actually a picture of my grandma. She got up early morning, went to the bathroom, and slipped, fell, got a little lightheaded, and complaining of right hip pain. And my uncle was the one who actually sent me this photo and was kind of asking me, what the next steps are. And, looking at this photo, we can take a look at that leg. We know it's externally rotated, it's shortened. She's complaining of hip pain, and, we're concerned for a hip fracture. And, I immediately told him to go to the hospital and, she's likely going to need surgery. A little bit about her story, almost 34 hours it took to have the surgery. A lot of pre-op pain, which really wasn't adequately controlled at all. And then, weeks of post-op pain, incisional pain. And she really suffered, and that got to me and made me question, how we manage hip fractures here at Jacobi, and, is there a way that we could do better for our patients? So that's kind of when this project all got started. We're 9 weeks in, and I'm glad that we've come this far. So the American, there's literature out there that we know that peripheral nerve blocks provide excellent pain relief for hip fractures in the elderly. There's strong evidence, both from the emergency medicine standpoint as well as orthopedic standpoint, that we should be doing these. So what exactly is it? The PING block, or the pericapsular nerve group block, is a anatomically driven block. There was a study done back here in 2012 that really looked at the innervation of the hip, and what it found out was that the anterior portion of the hip contains the most sensory receptors, and they're innervated by the articular branches of the femoral nerve, obturator nerve, and accessory obturator nerve. Well, the supralateral aspect of the hip is what innervates the mechanical receptors of the hip. So, Dr. Peng, it's actually William H. Peng who discovered this block in 2018 and described it in the literature, thought, why don't we deposit anesthetic right where the articular branches course over to innervate the anterior portion of the hip. So this diagram here, just pointing out a little landmarks to begin with. We see the anterior superior iliac spine. This is the bony prominence that we can palpate on ourselves. You go ahead and you come down a little medial and inferior to that, you have the anterior inferior iliac spine. And then you have the iliopubic eminence, which is right here. And the iliopubic eminence is the region where you're having the articular branches of the femoral nerve, accessory obturator nerve, and the obturator nerve course over to innervate the anterior portion of the hip. And these articular branches carry the sensory receptors of the hip, and you can see the femoral head over here. So why is it important? There are, other blocks out there that are done for hip fractures, specifically speaking, the femoral nerve block, the fascia iliaca block, and the 3-in-1 block. All these blocks tend to, result in incomplete or inconsistent analgesia. Reasons being that, for example, the femoral nerve block is only getting the femoral nerve and it's not getting the obturator or the accessory obturator nerve, which we know also carries sensory information from the hip. The fascia iliaca block in the literature tends to get the femoral nerve only and doesn't get the obturator or the accessory obturator, and that's similar with the 3-in-1 block. The lumbar plexus or the lumbar epidural block tend to cause hypotension, and all these blocks have the potential to cause muscle weakness, especially by depositing anesthetic near the femoral nerve. You can cause quadricep weakness, which can cause difficulties, especially with rehab post-op. So what do we know about it so far? The Peng block, like I mentioned before, is an anatomically based sensory only block, meaning that we're using ultrasound guidance to deposit a 20 cc's of anesthetic right above the iliopubic eminence, which carries the articular branches, like I mentioned, of the femoral nerve, obturator nerve, and accessory obturator nerve. So we're causing a sensory only blockade for pain. What's out there right now are just case series with clinical trials or randomized control trials in process right now. So this was after the Peng block was introduced. This was a case series that was done where they employed the Peng block to look at patients undergoing primary hip replacement versus revision hip replacement. They looked at around 10 patients, 5 in each group, and they saw for 9 out of 10 patients, there was 0 pain for 24 hours after the block was completed, and there was 1 patient who had a pain score of 4, overall showing excellent pain relief. There was another case series. This was actually done in Nepal, which also looked at 7 to 8 patients. And the goal of this is that since it's a sensory only blockade, they're able to reposition and move the patients around after the block was performed. And they saw that it provided excellent pain relief for positional pain as well. And like I mentioned, there are clinical trials in process comparing the Peng block to the fascia iliaca block, the Peng block to femoral nerve block, all which are active right now. And those have yet to be published. And one of the things we know about it is that this block has potential to provide excellent pain relief. So how exactly do we do it? One of the first things you have to do before you begin to do this block is you have to first decompress the bladder. So this is actually a patient that we had here in the ED that we were getting the images for. So the first things you look for is you look for a bladder, and since you're in the pelvic girdle, you want to make sure that the bladder is decompressed to avoid any inadvertent bladder injury. Some considerations you have to take is male versus female. Females tend to have a more broad base pelvis versus the male tends to have a more narrow pelvis. So it's something you have to keep in mind when you're doing this block. you have to take into consideration of the lateral femoral cutaneous nerve. This nerve tends to course right around where you'll be introducing your needle to do the block. So it's just something you have to be aware of. Now, if you're seeing a hyperechoic structure when you're fanning to look for, to do this block, is this something you would want to avoid? In the literature, there was talk about potential ureteral damage. This is not really an issue given that the ureters tend to dive deep and attach posterior to the bladder. So this is not something we necessarily need to be concerned about, something to be aware of. So this is a patient that we had here in the ED that actually had a hip fracture. Just to kind of orient you to what we're seeing here is we're seeing the femoral neurovascular bundle over here. You can see the pulsations of the artery and the vein. You're seeing the AIIS, which is the anterior inferior iliac spine right here. And here you're seeing your IPE, which is your iliopubic eminence. And you can see that here on the screen. The major landmark for this block is the psoas tendon, which is this hyperechoic structure you're seeing sitting on top of the IPE, which is the iliopubic eminence. And this is exactly where the articular branches of the femoral nerve, obturator nerve, and accessory obturator nerve are coursing over. So the goal of this pain block is you're introducing your needle in a lateral to medial approach in plane with the ultrasound. So the needle would come in, it would course through, this is your psoas muscle, coursing through the psoas muscle until you hit bone. So one of the, from a safety profile, one of the good things about this block is you're going till you hit bone. So you can't really overshoot the procedure. So once the needle gets down to bone, you're going to go ahead and rotate the needle 30 to 40 degrees to make sure you pierce the fascia right above the bone, and you're going to deposit 20 cc's of local anesthetic in a step-by-step manner, 5 cc's at a time, to ensure you're in the correct place. This goes, prior to beginning the procedure, you're going to make sure you employ sterile technique. The skin gets properly cleaned. You're going to wear sterile gloves. You're going to create a small wheel with lidocaine to ensure it's a pain-free procedure for the patient. And then you're going to go ahead and introduce your needle and come down to right above bone. A successful procedure means that the psoas tendon has risen and you're able to see anesthetic right here on top of the bone. Bupivacaine works great, and that's what was used when this procedure was first described. And we were able to see anywhere between 16 to 24 hours of pain relief. So with our patients, at least here at Jacobi, who come in with hip fractures, our orthopedic surgeons like to operate within 24 hours. So we're hoping this one procedure can really give them lasting pain relief until they have their definitive fix, which is their surgery. So some complications about the procedure that it's important for everyone to know. First is a failed nerve block. And one of the reasons why the nerve block would fail, once again, is that you didn't go down to bone and you injected intramuscularly into the psoas tendon. That's why it's important you make sure your needle comes all the way down and you're able to pierce the fascia above the bone. A hematoma can develop at the site, which has been reported in the literature when it comes to all peripheral nerve blocks. Since this block is in a compressible site, anticoagulation is not a definitive contraindication, a relative contraindication. And if you were to see a hematoma develop, you go ahead and hold pressure at the site. There's a theoretical risk of nerve injury, which is less likely in this scenario since we're staying away from the femoral nerve and dealing with tiny articular branches. There's theoretical complication of infection, which is diminished by using sterile technique. Lastly, allergy to the anesthetic. It's important we make sure we determine what allergies are prior to starting. And lastly, local anesthetic systemic toxicity when you have intravascular injection of anesthetic. And it's important to recognize the signs for that. It's usually altered mental status, tinnitus, and then cardiovascular collapse. And the treatment for that is intralipid. And one of the cool things about this procedure is just how away from your vessels you are when it comes to, when you're comparing it to the other blocks. You can see that your vessels are very much medial and the needle insertion and the deposit of anesthetic is very much lateral. So in terms of implementing this at Jacobi, one of the things, or one of the barriers we have to overcome is being able to teach this procedure to both attendings and residents. So we actually looked in the literature to see what there was in terms of a model. So this was a study that was done that talked about a low-cost reusable gelatin ultrasound phantom model for shoulder dislocations that could be used to practice with that Dr. Halpern talked about earlier. We kind of used this technique and created a model to practice image acquisition as well as insertion, practicing the block on a phantom model. So this was actually just done over the weekend. We went ahead and we bought a pelvis off of Amazon and a 15-liter bin. We used hot water. Hot water along with gelatin powder, when it mixed really well, forms this layer, and you go ahead and you put it in the freezer for about 4 to 6 hours, and you'll go and see the gelatin solidify. It's important when you take it out, you'll see these air bubbles on top. So you go ahead and you scoop out any air that's left over. Yarn and straws filled with ultrasound gel serve as great mimickers of both tendon, nerve, and vessels. So what was done is a straw was taken, it was filled with ultrasound gel to ensure that there was no air inside, and it was implanted into the gelatin. And yarn, which was soaked in ultrasound gel as well, was placed right above the iliopubic eminence, which you're seeing over here. Once again, to just orient you, this is your anterior superior iliac spine, which is the bony prominence you can palpate on yourself. You're seeing the anterior inferior iliac spine here, and then iliopubic eminence here. And you would see the femoral head sit right here. And this is your psoas tendon. So this is the marker, the landmark that you see when you're using on ultrasound. And on top of this, we went ahead and introduced another layer of gelatin. So now we have created a model that you can use ultrasound with to practice image acquisition and as well as practice the procedure itself. This is something we're hoping to try out within the next weeks and use in our workshops as we try to teach both attending and residents on how to perform this procedure. So our proposal here at Jacobi kind of has two phases. Phase number one is to conduct a 10-patient prospective observational feasibility/validation study. The purpose of this is to kind of show that we can perform this block in a successful manner, and we want to be able to monitor our results and see how effective we are with this block. The beauty of this is that something like this has already been done before with the fascia iliaca block. So we're essentially taking this study and replacing fascia iliaca with the pain block for hip fractures, and we want to see pain scores at predetermined timeframes for 8 hours, as well as the amount of opioid use. And phase two of this study is a 60-patient randomized controlled trial looking at the pain block versus our current standard of care here at Jacobi, which is parenteral anesthesia, and see how effective we can be with this block, and how much we can reduce pain and decrease the adverse effects related with opioid use. Lastly, I just want to say thanks to both Dr. Halpern, Dr. Dixon, Michelle, the whole ultrasound crew, and admin here at Jacobi for supporting me into involving this project and implementing this project. And I hope within the next few months we're able to start doing it on our patients. Thank you, Michelle.
And we should have. Thank you, Ani, for that presentation. We're just waiting. We're going to be moving on to the Q&A section. Thank you for those tuning in, for posting your questions on the chats. If you have any further questions, you can always email info@jajafoundation.org if you have any things that you didn't get addressed. And again, if you're interested in receiving the handbook. So we're going to go over a few questions briefly, and we will conclude our conference today. So the first question we have is via YouTube. How does one go get local anesthesia to patients with posterior shoulder dislocations?
So the posterior dislocation, basically if you can imagine, if you have that picture in your mind of the transducer on the patient's posterior shoulder, the posterior dislocation, the humeral head is going to move towards the back, anatomic back, and top of the screen. So it's the same. You'll still have your target being the joint space right in front of the glenoid. So it's the same approach. It's just recognizing that the humeral head in a posterior dislocation moves towards the top of the screen, and in an anterior dislocation moves towards the bottom of the screen.
Great. So we also have another question via YouTube. I think it's via the same user. Is there a way to identify pneumonia and non-basal lower chest infections via ultrasound? And again, I want to remind you, right, like ultrasound is a super dynamic imaging modality. So wherever you put your probe, you can detect pathologies. You can certainly detect pneumonias in different areas of the lung. In general, as I mentioned in my talk, if you're suspicious that there's a pneumonia going on, you can scan on the side where the pleuritic chest pain is happening. Hepatization is not always going to be present. You can sometimes you'll only see focal B lines right where that pneumonia is affecting the lung. So, I would encourage you, to start with the general scanning protocol that I discussed. But if you're suspicious that there's another area of the lung that might be affected or has a pneumonia pathology going on, you can certainly put the probe on the area and see if you see any findings suggestive of that. It's not only for basal pneumonias. So we have another question from Shirley Demetrius via Facebook. Let's see. So thank you for joining us today. She said PGY1, so that's awesome. We're happy to have you here. We hope we've inspired you to put the probe on all your patients to practice. All right, so the first question is, was the cholangiocarcinoma seen on ultrasound along with the typical ultrasonographic signs of acute cholecystitis? This question would be for the team at the University of the West Indies, if they're available.
Maybe we can
All right, if we don't have the team available from the,
Hi.
Oh, there we go, okay.
That's a little technical. So essentially, we did not identify the actual mass on our point of care ultrasound. That was identified on the CT scan that was done. But we did see the duct dilatation, so we knew there was something there.
Awesome. There's actually another question for your team. With performing the ocular ultrasound, how did the quick time to diagnosis of retinal detachment aid in the management of the patient from the ophthalmology aspect, and did the patient regain vision?
I think what it did in this case, because it was a MAC off detachment, so you're able to triage a patient to either emergent intervention or to urgent intervention. And so the patient did see the ophthalmologist on the day who confirmed our findings, but the actual surgical procedure was delayed. As the presenter mentioned, once the macula is gone, there's less urgency to do the surgery. But if the macula has been spared, then it becomes something that needs to be done right away. Unfortunately, I gather that the patient defaulted and did not return. So we hope wherever he is, he's still seeing.
All right, but at least, you have much more informed management. And I mean, unfortunately, we can only control so much when we see our patients. But that was an awesome case. So next we have a question from the same user. When OBGYN comes to evaluate the patient, do they also see the free fluid or not so free but heterogeneous fluid and quickly rush to the OR, or do they look for an ectopic source? So again, remember that when we're scanning patients in the emergency room, we're ruling in or evaluating for specific things. When there's a patient that's pregnant and there's free fluid, that's suggestive of a ruptured ectopic. Now, how that this patient definitely needs an evaluation by OBGYN, either for admission, laparoscopy. And I think I find in my practice, the primary way that these patients are expedited in terms of their management is how stable they are. If the patient is hemodynamically stable and has free fluid, in general, they're admitted for confirmation or further evaluation and possible laparoscopy to see if they see an ectopic. I've had cases where the patient's pregnant, there's free fluid, unstable, and they go up to the OR within 20 minutes of presentation. So ultimately, I mean, if you have a pregnant patient, you don't see an IUP, and there's free fluid, that's a ruptured ectopic until proven otherwise. And depending on how stable they are, you have a little more time, but definitely it warrants a discussion with your OBGYN team and likely admission for further management. So we have one last question here by user Errol Williamson via YouTube. How does one identify a probable pulmonary embolism via POCUS? So again, we did not cover all of the core emergency medicine content that we are expected to be proficient at. This is a whole lecture potentially on its own. In general, for PE evaluation, you're gonna want to do cardiac ultrasound. There are specific, there are certain signs that you look for on cardiac ultrasound to see if essentially there's right heart strain. You're not able to really see the clot in the lungs, but there are signs in the heart of obstructive shock that can direct to see if PE is a possible diagnosis. I encourage you to look online. There's a wealth of resources, including 5-minute sono and the ASAP document to read specifically for diagnosis of PE. You're gonna be wanting to see signs of right heart strain, which can be a whole talk right now, but I don't know if we have the time, unfortunately.
I would just say that you're looking to be highly specific and rule in disease with RV strain or septal bowing on your echo. You can also rule in a clot in your DVT study. But we know that POCUS is insensitive. So because you don't see these things does not mean your patient does not have a pulmonary embolism. It's a real important distinction. So highly specific, you can rule in. If you see RV strain, if you see a clot in the leg, but insensitive. So if you don't see it, that doesn't mean your patient doesn't have a PE.
Right. So again, everything within the clinical context and understanding the limitations of your studies. But yeah, lots of stuff out there on the web to learn, and we have the best teachers, which are our patients. Practice as much as you can. So I think that's those are all the questions we got for today. Again, thank you for everybody that tuned in. We really appreciate you sharing this day with us. We hope that you walk away inspired and have learned something useful and new for you to, as you work clinically, to integrate into your armamentarium of tools. Thank you for all the presenters, Dr. Sonnenthal, Dr. Ramachandran. We have Dr. Dixon and Dr. Halpern, and of course, all the presenters that tuned in today. Everybody that assisted behind the scenes, thank you so much. I'd like to thank also Orlando Dillon from Evisive Media for providing live streaming of the event. Thank you so much. We would, this is like way beyond our skill set, so thank you. We appreciate you making this possible. Garvin Gray, the media strategist for the Jaja Foundation, for providing all the video production for the event. I think I speak for all the team. We are incredibly grateful to Miss Karen Shields. Thank you so much. You have been amazing from the initial idea to have this conference to now. We really thank you for organizing everything and being such an amazing amazing person. Like, we really are so grateful for all your help. I'd like to thank Dwight Shields, the director, Delta Wright, sponsorship and communication coordinator for Jaja. Thank you for all the volunteers for their continued support and commitment, and for the participants for joining in. Again, make sure you fill out the CME link. You will be receiving a CME certificate via email in the coming weeks. And yeah, thank you so much. Bye from New York. We will have Dr. Dixon just say a few words before we log out. Just give us a few minutes.
Hi, everyone. I just want to thank everyone for a really great conference we had here today. I couldn't have done it without all of you, all the folks who logged in from Turks and Caicos, St. Lucia, London, Jamaica, all over the United States. Thank you for supporting the Jaja Foundation. Thank you for tuning in so you can better serve your patients. I'd like to thank Dr. Wong at KPH. I mean, some of these names are kind of repetitious, but it's really took a team effort to make today possible. Dr. Wong at KPH, Dr. Simone French at the University of West Indies and her team, Jacoby, the leadership here, Dr. Sperlin, Mike Jones for giving us the support and the latitude to take on this endeavor, okay? The ultrasound fellows, Dr. Montenegro, Dr. Sonathal, most of the presenters are part of our regular medical mission to Jamaica. Dr. Hackett over there in Houston and Dr. Jeff Kim, who's actually in Ecuador, they're part of our General Jaja Foundation ultrasound team that goes to Kingston every year. And of course, Dr. Ani and his presentation on hip fractures, and we'd like to thank him for doing his presentation on the Peng approach. He's a first-year resident, and he's very promising, so I'm sure we'll see him again in the future. We have some exciting things going on here at Jacoby, and we're only able to do this at Jacoby Montefiore residency program because of the latitude that the leadership gives us. We have a lot coming on the pipeline. We're going to be doing TEE studies later on for those of you who want to learn more about that. My partner in crime, Dr. Michael Halperin, all his support. We just move forward. We have a vision, and he supports me, and I support him. And we'll be able to make lots of headways here at Jacoby because of our partnership. Of course, some of his names we mentioned before, Ms. Delta Wright, Garvin Gray, Orlando Dillon, and Miss Belinda Tavares here at Montefiore, who came over to give us a hand. Thank you. And last but certainly not least, we want to thank Karen Shields for her ongoing support in all that we do from the Jaja Foundation point of view. Thank you to my wife and family who has tolerated me for the last couple of days with my neurotic self. So thank everyone for being here, and Godspeed, go home safe, and stay safe from COVID and social distance, and be safe. One love.